So, by show of hands, can I know who all of you guys are actively preparing for the AMC clinical exam and kind of have a little idea about the structure, a little idea about, how the cases come? Just show of hands with your like emoticon. And yeah, actually raising a hand. Okay, good, good. Susan, yes, yes. Okay, good. I can see the list. Okay, Usha was there. And then, okay. Four yeses. Okay, so I'm gonna guess, apart from me and Liz, the rest of you guys kind of don't know, have the idea. And then, sorry, more than four, because online as well. Okay, cool. And how many of you guys have a date for the exam? Apart from Swarna, Apurva, when is your exam? And Susan, when is your exam? Sorry, you're muted. No. Wait, is it me? No.
No, we can hear you.
Yeah, Apurva, I don't think
It's
I can hear you, Sudha. Um,
15th October. One has 15th
15.
October.
Check your audio as well right now because if you're going to be role playing, you need to have your audio working. That is minimum. And Prakashini, when is yours?
2nd of December.
2nd of December. Susan is you Purva, 21st October. Still check your audio because I need to hear you talk.
15th of
Uh,
October.
15th of October. All right, cool, cool, cool. And anyone else with an exam date? I'm just trying to go through the hand. All right, cool. And I know Swarna does, and I know a couple of other people. Liz, can you just check on the WhatsApp group when they're joining?
Yes.
Cool. And how many of you guys, okay, so those of you guys are taking the exam, okay, before we go there, how many of you guys are actually planning to role play today so that I'm not picking on people that don't want to role play? Prakashini, you got to role play, you got your exam dates.
Yeah, she just
People
started.
who have exam dates is not an exemption. You cannot ask for an exemption when your exam is just around the corner.
You can chat to Liz about that. We already had a session, Liz and I, and she goes, "You don't need to role play today because it's your first session."
Yeah,
No,
she just
No,
started.
sorry, Liz.
absolutely not. Okay, cool. All right. So,
I
okay, so
can
let's
try.
start with this. Sorry?
I can try. I've just started role playing, so I can try for
Good.
an easy case.
For an easy case. Okay. So, today's session, I'm obviously not going to tell you what cases we've picked up because that is kind of how the sessions happen. Because if I tell you what it is, then it's not going to be like how it's going to be in your exam. Okay. And that is the whole point of these sessions. So I want to tell you a little bit about who I am and what I do so that you guys kind of get a perspective that you're not learning from someone's completely not credentialed to teach you this. Okay. So my name's Priya. You can call me Priya or you can call me KP because my name's very long. I am an FACEM trainee in my second part of my FACEM training. I'm also the IMG representative for the state of WA and federal for the state of WA. I'm the chair as well for that. And currently I'm in my ICU rotation. Um, and I have been teaching the AMC exams for the last 8 years. And specifically, clinical is one of the areas that I love, and I also kind of teach on the floor because I have a lot of juniors that I'm responsible for on the floor as well. And apart from that, I am also current. So a little bit about us. We are also now just in collaboration with the AMAWA. We'll be running clinical courses for all IMGs, and we're trying to get like discounted prices for you guys if you guys are AMA members, so that you guys can basically do it at a cheaper price. And it's all for physical exam that we'll be starting in September, and we'll be running it through and seeing how that goes. Apart from that, we have currently we're restructuring our clinical course mainly because I've realized that a lot of you guys, like you guys right now, who have your exams in October and in December, are very shy to role play. And the only way to pass this exam are for, if you notice, the candidates are that pass the exam are the candidates that are not shy and actually role playing and making the mistakes. Knowledge is one thing, but actually role playing the cases is different. Okay? Because you guys are great clinicians on the floor and in ED or wherever you guys are working. But the issue is when this is not an actual ED or a hospital or GP setting. This is actually an exam setting. So you have your exam nerves, you blank out, you have the like other additional factors that don't play into it that you'll need to know how to actually work your nerves and get used to all of this. So I always encourage people to role play, be proactive, and that's so how we're restructuring the program is that we are running now 4 months courses that have been running for the last 2 years plus. No, not 2 years, sorry, last 8 years. What am I talking about? Last 8 years. But the structure how we're changing is that you guys get to each month will be a subject month. So if you feel like you're weak in psychiatry, come join us with psychiatry. You don't need to take the whole course. How it would, if you're taking the whole course, you'll be given theory videos, notes. You get full access to all role play sessions and classes till you give your exam. There's no subscription period. And you have access to all our mentors and you have all typed out notes, videos, everything given to you at the first get-go when you sign up with us. And you have unlimited classes you can attend. In terms of, and that's a 1,500 for the entire course. For those of you who guys just want the subjects, that will be 6 classes total, each class 3 hours. It would be four role play sessions, no theory, as in no theory during the class. It will be just role play. And it will be about 4 classes of the subject plus 2 additional classes of the recent recalls of that month. Okay, month and counseling sessions what comes in your exam in that month. And if we feel like it's a medicine topic or like certain topics are quite heavy in the topics, then we add the number of classes for that month. Okay, so we kind of get you more classes for that month and we kind of get you role play. There is no theory for that will be provided. It will be just your role play, one-on-one feedback and kind of getting you polished. And those of you who take the entire month, you get that subject's notes, but not other subjects' notes. Okay? Does that make sense, guys? Any questions? Cool. Yes, good. Amazing. Did Prakashni just turn off her camera? Like you just turned off your camera. Did I scare you away?
She's fine.
No,
She's
I
fine.
was just having to do something, so I turned it off.
Okay, that's fine. I mean, you can do it right there. Like, I'm okay as long as I know you guys are on the other side. All right, cool. So, what we're gonna do is we're gonna get going. Liz, you want to introduce yourself as well?
Sure. Yeah. I'm Liz. Many of you guys might know. I'm friend of. I did not have a chat with KP about it, but I'm friend of Pragashini also. That's why she was. She
I know
just
that.
had her first lesson. Yeah, anyways, so I am Linus Liz. I completed my AMC, MCQ, and AMC2 this year, like MCQ in 24 and AMC2 in February, very recent. And then I am doing my observership in Austin, in Melbourne. Yeah. And then that's it. Yeah.
Very
I
good.
also teach AMC, MCQ, and clinical like this with KP Balan. Yeah, I've been teaching since 24 AMC, MCQ, and doing this since this year.
Amazing. Yeah. So she does work with me. Yeah, that's pretty much us. Do you guys have any questions before we start? Anyone, this would be the time to ask questions. Otherwise, we'll be reserving the questions till the end of the session because otherwise it'll be too long. Any questions, queries? Cool. So counseling sessions and counseling role play sessions, do you guys have what are the things that you guys are finding hard when you're role playing? Or when we say counseling session, what is the most difficult things for you guys? Guys, this is a very interactive session because it's a clinical exam. So please turn on your microphones and actively participate. Or
Yeah.
I'm gonna,
So I got like 7
counseling stations in my last attempt, and out of which I could get through five. And one case which I still don't understand why I didn't get through is the sleep deprivation counseling.
Hmm.
So I have told everything, like everything was already ruled out in the question.
Hmm.
But you have to basically explain the person about sleep deprivation, maybe make a diagnosis of why she's having, like, primary insomnia or secondary insomnia,
Yeah.
and just tell her that everything dangerous was ruled out already. Like I
Yep.
like OSA, a certain anxiety, depression is already ruled out. What
Yeah.
you're having is a primary insomnia because of previous stressors. She had like exams going on. So I told that, and then I gave her like the sleep hygiene full like info. I
Yeah.
don't know where I still don't know where I lost marks.
No, that's fair. And I think that's the hardest part with
Yes.
these ones, right? Because you don't know. Now it varies from subject to people to people as well. And we kind of have to look at your feedback sheet to kind of see where actually you lost your marks. Like if and then have a chat about it. But yeah, so I mean, when the case comes, we can definitely have a chat and see if you've done everything. And I think it's hard to nitpick also an exam that you've done because one, I don't want to make you feel like crap. And two, like,
Yeah.
do you know how like when we go back, oh, I could have done this, I could have done this is always
Yeah.
a feeling. So you guys all have your exams and kind of focusing on how can I make my next exam better would be ideal. Yes, one of the worst things with the AMC exam is kind of not knowing where you went wrong because they don't give you adequate feedback, and we're kind of working on that. But we will kind of approach that a little bit better. Anyone else have any other qualms? I'm happy to hear all the qualms because it helps me in my role as well. So,
Yeah, even I got that squamous cell carcinoma counseling case once in the last time. That also actually I was very confident. I was counting, okay, this station I'm like I'll pass. Like because I one thing like I was about to give more empathy, but the patient was absolutely fine. She just want to hear the like what is the management further thing. I think only thing maybe that MOHS I couldn't figure it out the full form at that point. That surgery, that
Ah,
micro
most
MOHS surgery,
oh,
yeah,
oh.
that I just mentioned MOHS. I couldn't get the abbreviation that time. I was not getting that. Otherwise, I think she was also convinced. She was happy, like all the points, like cryotherapy, radiotherapy, and that sunscreen thing. Family also has have to screen about it. Everything. I was very happy, like at the end. But that also actually, I don't know where I went wrong, and yeah.
KP, KP, I just wanted to add there. Like counseling is a station where everyone says this. They are like 100% sure that all the theory is put out there. But often I hear from candidates saying like, I did everything I could in a counseling station, but I did not know why I did not pass. Like counseling is a station where that happens often, unlike the other stations. So yeah.
I completely agree, and
Yeah,
it's
and
also
there are one few. Yeah.
yeah. So one of the things about counseling station is one thing to be very careful about counseling that you're not regurgitating theory. So that is very important in a counseling station. In reality as well, when you're counseling a patient, be it cancer cases, be it any cases, regurgitating theory, it sets off the examiner and they will not pass you. So that's one of the things. So we're going to go through some do's and don'ts of the clinical role play. Yes, Apurva. Uh, no, you're not still audible. No.
I
I
think
think,
your mic, you just have to work or click on the microphone or the audio or speaker or lose the thing, the headphones.
yeah, the Sony headphones act up. So I try to not use the Sony headphones. Try and make sure if you guys are having trouble with audio, just hover over the microphone and make sure your input is from your microphone and speakers from from the computer. Try logging in and out otherwise. Okay. All right, perfect. So I'll probably type it out for now because if you're gonna lose that time. All right, can I ask all right. Anyone else have anyone else who has had trouble with counseling stations?
I think that's it. Like, even though our theory is correct, it must be like you have to present it in a way like you're talking, not like lecturing the patient, is
Correct.
my biggest learning after that. Like, you have to give enough pauses, you have to keep checking on the patient. I think, like, once all of us like do a practice, that's when we will know of our shortcomings.
Correct.
It's, yeah,
Absolutely.
yeah.
Absolutely. And that's what kind of what we're gonna do today. And uh main thing about the counseling sessions that all of you guys are focused on getting to the end of the thank you statement and kind of, providing them with supports and stuff. But if
The
they don't,
4 hours, like everybody runs to the
like
4 hours.
everybody else, but if you don't feel like they're heard and if you haven't ruled out like very important statements, then like there are some certain key statements that you will see in the role play cases that you will do today. It will be you'll understand. Now today we have 6 cases just to make it easy. Can I have in the message section say who is actually willing to role play today and I can assign them cases so that we can have a good flow. So Swarna, I know you're role playing. Cool. So Swarna,
Yes.
I'm gonna
So
give you
I'm like,
I
Hello.
I
Hello. Am
want
I
to like
audible?
call out all the people who have not opened their cameras. Like I
Am I
think
audible?
they sit in. Oh yeah, you're back, Apurva.
what was that?
Yeah, so my question was for Neerija, Dr. Neerija.
Okay.
Was it like the patient asked you for the full form of more surgery, or was it from your side only?
No, actually, she didn't. Like, even I was after getting the score result, I was thinking maybe whether, like, I was trying to figure it. Like, whatever, she didn't ask any questions back. Like, I was just giving
First
all the
of all,
advice. She was, ah,
so first
All
of
right.
all,
sorry.
like I like so first of all, like just from an outside perspective, if I was doing that station, if I was doing the skin cancer counseling station, I would not mention Mole's surgery. Why is that?
Yeah.
It's a good case. Tell
Because,
me, why would I'm a resident medical officer or I'm a general practitioner. I'm seeing
yeah.
my patient, I'm
Mm-hmm.
counseling the patient. Why am
Mm-hmm.
I not going to be counseling my patient and telling them that is the surgery that they'll be doing?
No, until and unless they have an issue with the scar and they're not ready for a re-excision, that's when we provide alternatives. If they're happy with again a re-excision where we're not sure of the margins, why would we still do a microscopic surgery? And again, it's not as effective as a wide local excision.
No,
That's
actually,
that's
she was concerned that time. Like when I asked about the excision, she was like, because the incision was in the temporal, in the face. Okay, she is
Yeah,
very
yeah,
much concerned. So I just given the
fair,
option.
fair, fair.
yeah.
But why would still if I was doing the exam and when I did the exam, I would not give that as an with the name specific. I'm giving you a hint, like with the name specific, I would not mention that surgery. Does anyone have any clues?
I think
Um,
because you're in a role of a junior doctor and it's not up to you to decide what kind of surgery. So maybe the best thing you'll have done is I will refer you to the surgeon who will decide what they're going to do for you.
Correct. I'm
Right.
not a specialist in that area. I'm not doing the latest procedures. It is not my role to see because we are not completely aware of all the procedures that are available for skin excisions and all of that. So we're actually not the best person to decide that. We're in a junior doctor role, and you have to be a safe doctor. So GPs don't like you giving, so they don't like you giving actual treatment names. Does that make sense? Like even if I know that okay, someone's going to be in a CHOP treatment for an immunotherapy for a cancer treatment, right? I still would not mention it. Does that make sense? The only ones you can actually mention is emergencies such as anaphylaxis, your bleeding, your postpartum hemorrhage, your venous hemorrhage, your arterial hemorrhages, your anaphylaxis, all of those emergencies you must know as a junior doctor. Does that make sense? But the rest, no. That's why even in this exam, you do not prescribe any opioids. The only condition is ACS that you prescribe opioids. Why? Because you need a senior approval to prescribe opioids here. Does that make sense? Yeah? Like I had a lady yesterday with dissection. The junior is still not allowed to, the person that's going to be prescribing that fentanyl is the senior doctor and not you. Does that make sense? And then a senior
In
doctor
what,
will come back and change it to morphine.
yeah, what condition you stated as exception, doctor?
ACS,
Right.
acute coronary
Thank you.
syndrome. That is the only condition where you're allowed to prescribe fentanyl or morphine. Does that make sense? Or any opioids for that matter. Back pain, you prescribe opioids, is straight fail. Does that make sense? So that is exactly the reason why you don't, okay? So we'll go into that and you'll understand that when we do the cases. So today's cases that we're doing, it's quite different. It's not your routine regular cases. These are all recent recalls in your July exam. And we have taken that from your exam. So we're going to be doing those. Swarna is going to do role play. Who else is doing role play? Come on, guys.
I will try. Yeah.
And Susan's doing it as well. That's 3. We have another 3 more.
I will try as well.
Hi. Yes, Ritika. Good to see you.
Yeah.
Yeah. Okay. Who else? Prakshini, are you going to try?
Susan, yes.
Susan said that's 4. And I'm going to assign you all some numbers. Who wants the easy case? Prakshini, if I give you an easy case, would you do it? Come on. All right. Usha, how are you? Are you there? Are you guys there? You guys have to speak, guys. Come on. You guys can't just be online. Like, that's just not done. Hi, Usha. Can you turn on your camera? And are you happy to do a role play session? I'm just randomly picking.
Alia, people are having exams.
Sorry. Usha, are you there?
Yeah. Sorry, to be honest, my study partner is in the session too, and
Oh,
she's having
Bhagat,
the
Dr.
exam.
Bhagat. I don't know if you're there.
Dr. Bhagat. She
oh,
can do
yes.
the session actually. She can do the role play because her exam is coming up soon.
Yeah,
Okay.
Bhagat. I'm
Yes.
calling for Bhagat. She's having a
Yes.
date. Yeah.
Yeah.
Wait, Bhagat is your study partner?
Yes.
All right. So, Dr. Bhagat, can you turn on your camera and say hi to us?
See, guys, like, let me just tell you, AMC Clinical is all about coming out of comfort zone.
Yeah.
You are supposed to, on your cameras, read. It's like you're all adults, we don't have to tell you to do certain things, but it's all about coming out of comfort zone and talking. Australia is all about talking. You have to talk. You have to talk to a person who has just said, "How are you?" or "How are you doing?" It's all about that. So if you're not comfortable coming out showing your face, it's going to take a lot of effort in passing the clinicals.
A lot.
But we completely understand why you're in this situation. We completely understand because I also came from the same situation. I was also shy. But then really, it's all about role playing.
And just to reaffirm, whatever we do, like it's not a criticism of anything that you've done or not done. It just helps you for the exam. I see Sai's video on. Sai, are you happy to role play?
Yes.
And Sai, tell me a little bit about yourself. You are giving the exam, you have a date, you have tried the
Yes.
exam before.
No, I didn't try it, but I'm giving exam in September 23rd.
Okay.
Oh, awesome. All right. So Swarna, you get
started, Sai.
one second. I'm just giving you guys the numbers. So I have the actual
Okay.
number. 3, 4, 5, 6. So Swarna, I'm going to give you 3. Case 3. Are you there?
Yeah.
Yep. Sai, how much prep have you done?
Not much.
Okay, that's fine. Then Sai, if you're happy to start, I'm going to give you case 1.
Oh my goodness. Okay, I will
You'll be
try.
fine. Okay, yeah.
Okay, I will try.
Yeah, give it your best shot. And then I have who else? Then it's Susan. You're getting case 2. Then you have, who was the other person that, Ritika, you're getting case.
4, 5.
Oh yeah, I'll give case 4 to Ritika. Ritika, you get case 4.
Yeah.
Okay, and who was and Neerja, was it? Neerja, you get case 5. Yeah? Okay, and then if we have time, case 6, who was the last person that volunteered?
Apurva, right? Did
Apurva?
Apurva? No,
No.
she didn't.
Apurva, you're doing case 6.
All right. Actually, it's my first time. I can try.
You
Yeah,
should.
yeah,
I
that's
mean,
good.
do I look scary? No, right? Good. You should
No,
try. Okay,
You
good.
do sometimes.
I
I
do
don't
look
know
scary.
what to do. No, I don't know what to do.
It's
Just
okay.
guide
We
me.
won't reach case 6. Don't worry.
You'll be fine. Case 6 is fine. Okay, so can we go to the next slide?
Yeah, that's a station.
Oh, then go back, sorry. Can we, 1 second. I'm just gonna get you to stop sharing real
Yeah.
quick. I just want to kind of go over the ground rules. All right.
Did I not stop sharing? That's you. Okay.
Okay, cool. So counseling station, the difficulties we kind of went over, and what are they looking at? So in counseling station, the basic thing that they're looking at is your body language. So that's why your camera needs to be on. How you react to my emotions is very important. Your words that you use and the exact wording is actually very important. So please be aware of what words are you using. If it is guys, you cannot use confidentiality statement for everything. So if you're using it as a blanket rule, examiners do fail you and this is from an examiner's mouth, it's not from my mouth. They do fail you if you're throwing the confidentiality statement left, right, and center. Being a safe doctor is very important. So if you're actually doing opioid prescriptions and actually doing mentioning the actual surgeries, which can be all wrong, is one of the reasons that examiners fail you. So make sure you're a safe doctor when you do so. And last but not least, the main thing is that you are giving them adequate information, you're safety counseling them well, and then going from there. All right. So that's one of the main reasons. So your communication skills is what is being tested the most. Now, in terms, and also, yeah, don't lecture me. When I'm in my vulnerable state, hearing a lecture from me is the last thing I want to hear, right? So that'll be a straight fail. And then do's and don'ts. So don't use medical jargon. Think of that you're talking to a child. That is the best way to kind of approach a counseling station, okay? Because we do become a child when we're in a vulnerable state. When a patient's talking, do not interrupt them. And memorize speeches, memorize sentences. We can actually tell you when you have memorized a sentence. And if you have, it's not a pass, it's a fail. Okay. And then ignoring the emotions, like I'm crying my ass off, and you guys are saying, okay, let's talk about other things, and let me start prescribing you things, and let me just, I was like, well, I'm crying here. Can I get can I get a tissue? Very important. Okay. And that is why you see people saying, hey, I didn't even finish the station, but I actually passed the station. How did I do that? Does that make sense? Because you actually address the concerns. Okay. Don't promise things. It's a straight fail. You cannot promise someone that you're not going to die. We're humans. We're all dying, but you also don't need to tell them you're going to die. Does that make sense? Okay. And then trying to rush through and then forgetting to safety net. And useful phrases that Liz has kind of put together, and I thank her for doing this, because I've been on a run nights, is one of the main things. Oh yeah, and don't make up words during your counseling sessions. I've had a lot of candidates that make up words, and making up words is a straight fail. Main thing to address is that I can see that you're worried. Let me ask you a couple more questions to see how I can help you. Can I go home now? I just need to ask you a couple more questions and then I can see how I can help you. Does that make sense? Those are the statements that you need to use. I've not addressed the fact that they can go home because I'm false promising. Does that make sense? Um, saying that I know what you're going through is a straight fail. Okay? You don't know what they're going through. Yeah, I can understand what you're going through is a different statement. Okay? Hi, Apurva. Yes.
What do you mean by making up words?
I've had candidates making a word say you need to unalcohol yourself. That is not a word. If saying words like, I know it makes sense in our own language, and that's like the hard part, right? But like said, you need to de-alcohol yourself is the other one I got. Not a word. You need to the other ones.
Yeah, I got it. Okay.
Yeah, there are a couple of them like that, and it's usually comes in your under pressure, like you're feeling pressured and the patient's acting erratically, and that you're like, I don't know how to respond to this. Because when was the last time you approached an erratic patient? Someone's like yelling at you, at your face, or just all over the place. Not in a while, right?
Yeah.
Yeah. Well, that's pretty much every day on a shift for me. So that's what you will be facing. Like literally 100% on a shift, I'll be facing someone yelling at me. Does that make sense? So that is
Yeah.
something that you'll be facing, and that's what they want you to prepare you for. That you stay calm, collected, and you're making eye contact at the time. Okay. And
Right.
just and yeah, and other than that, like things saying that does this make sense? Like it's not really a nice sentence to say. Like if I ask you, does this make sense? You'll be taken back, right? Like it's more so like, are you with me so far? Like, do you have any questions? It's a better polite way of saying things, right? Does that make sense? So the way we phrase it in a counseling station is very important. Now, and other than that, so those are the main things that you have to worry about. Is that clear? Okay.
Yes.
Good, cool. All right. Learning points, slow down, pay attention to the person's emotions, use your body language, don't be judgmental, consent the patient, discuss if need be, and be aware that you also have a differential diagnosis in counseling unless it's a confirmed diagnosis given by a biopsy result. Okay, or genetic testing or any other testing, and there's a confirmed result, you can't really say that is it. Does that make sense? Cool. You have to give the credit to the patient. Cool. All right, let's get started. Okay, Liz, I'm going to give you the.
Sure. Okay. Who is going first? Who had case one?
Case one is Sai.
Me.
Okay,
Yes.
let's start. Are you ready?
I'm gonna
Yes.
give you 10 minutes on the clock.
Okay,
Cool.
you'll be role playing this case, and I'll do the timer for this one, and then you'll have KP to do the role play for you. Okay? Okay. Are you ready?
Okay. Yes.
You have 2 minutes reading time, and then you'll have 8 minutes for the session. Your
Okay.
time starts now. Yes, you may answer. Can I confirm your name,
Yes,
please?
I'm
And this,
Dr. Rupa.
that's good. Okay, do you have any questions?
No.
No, this is your patient, Peter. You can proceed.
Okay. Hi, Peter. I'm Dr. Rupa. I'm one of the junior doctors here today. How can I help you? Okay.
KP, you're mute. You're mute.
So, doctor, I'm a shift worker and I kind of have been having difficulty sleeping. And my work is also really stressful. It's a lot of pressure at work and I'm having a really hard time sleeping. So I just need a, repeat prescription for diazepam. I saw another doctor, I think a colleague of yours in your practice, and had given me 3 months supply of diazepam. I just can't sleep without it. And work is just stressful and I just need another script.
Okay. Since how long you're having this sleep deprivation?
Oh, at least for more than about 4, 5, 6 months now almost.
Okay. Have you tried any other methods?
Oh, I tried exercising. I tried to sleep one time, but it's just the stress in work is not just helping me at all. So like, no, that's about it.
Okay. You started taking diazepam since 3 months, right?
Yes,
Are you taking it regularly?
I am. Yes.
Do you notice any side effects with it?
No.
Okay. Are you comfortable with taking diazepam?
Yeah.
Okay. You are mentioning that you are not able to sleep without it, right?
Yeah.
Since how long you are dependent on it?
3 months, like I said, like I'm not dependent on it. I'm not an addict.
Okay.
Like, don't get me wrong, like I'm not an
Okay.
addict, but I'm not
Okay.
dependent on it. Like I have a very, you don't understand, doctor. Like I have a very stressful work.
Yeah, I understand. I'm so sorry to hear that. Do you smoke or drink alcohol?
I do smoke. I smoke about 10 cigarettes a day.
Okay. How is the sleep deprivation affecting your daily life?
I don't think I have sleep deprivation because last 3 months I've been on diazepam and it's been good. So that's
Using
like
diet? Yes,
yeah. Can I get another script?
okay.
I'm just here for script renewal. Is that okay if I can just get that? I'll be out.
Is it helping you, diazepam, like you're getting enough sleep and are you able to do your work with it?
Yeah, absolutely. Otherwise I wouldn't be asking you.
Yeah. Do you have any other stresses apart from work?
Like what?
Like any emotional disturbances, family disturbances, relationship?
No,
Okay. How are you coping emotionally
I'm
through
fine.
your work?
I'm fine.
Okay.
Sorry, doctor, can I just because I have to go back and sleep. Is it okay if I can get the benzos, please?
Okay. Before giving the script, I would like to ask few more questions. Is that okay?
Okay.
Okay.
Sure.
Do you use any recreational drugs?
Sorry, can I sorry, before I answer that question, is it okay? Like, so if I answer these questions, I'll definitely get the prescription.
Yes. I will
Okay.
try to give, but I'm not sure. But before that, I want to know few
Sure.
things.
No problem.
Do you use
No, so I used to do speed, and now I've kind of stopped. I sometimes take marijuana, not regularly, just occasionally, but that's about it. Nothing serious.
okay? Are you taking currently as well?
Yeah, so I smoke like marijuana like once in a
That's
while,
your
yeah.
timer. You can
Okay.
move on.
Since how long?
Oh,
That's your
since for the last 25 years.
Okay. Okay. Do you have enough support from your family or friends?
Yeah, I do.
next task, please.
Okay.
Move
Okay.
on to the
Sorry.
task. Yeah.
Hi, Peter. Thank you for answering all my questions. But before going to give you a repeat prescription, I would like to say it is not very good to take diazepam for a prolonged period because it makes you dependent on it. You will also get some side effects by taking the diazepam. Uh, It may cause extreme sleepiness or tiredness, and it also cause some muscle weakness. Sometimes it may cause unsteadiness and changes in your mood. Uh, these have very serious side effects, and it has a higher risk of dependence, and there may be a withdrawal symptoms as well. It is good to stop the diazepam. And you also said that you are taking some recreational drugs, like taking the diazepam may be dangerous along with these drugs. It may cause you overdose. Stopping the medication like suddenly also can cause withdrawal symptoms like shaking or sweating or some stomach cramps and seizures. This might be difficult for you because since you are using this one 3 months, we can try you on other methods like talk therapy or sleep hygiene, yoga or meditation, which may help you relieve your stress. It is not good to depend entirely on the drugs because it has its own side effects. But the advantage is you are having good sleep, but it is not good to take for a long time. Are you with me?
Yeah, but I don't know why you're saying all these things. I'm actually not I'm not dependent on it. Like I'm actually fine.
Yeah, you are actually fine with the medication, but we can try other methods of sleep hygiene so that you can not use the medication so long. By using medication so long, you can have some serious side effects. It might impact your health as well. And it is also good to stop taking the recreational drugs so that you can get enough sleep.
I'm not a drug addict. Like
Yeah,
I'm not a
you are
drug
not.
addict. I just want to be very clear. Like I'm not a drug addict. But like, and I only do like marijuana just to like chill a little bit after my hectic shifts and my hectic work. Like I don't do it every day. I don't need it every day. I'm not really addicted to it.
Yeah, I understood. But it may cause some serious side effects on your health. To prevent it, we can try other techniques like meditation or yoga. It might help you, like walking in the park, may help with your sleep deprivation or stress.
Okay, so are you gonna be prescribing me medications or not?
Uh, Before I was prescribing you, I want to know your mental state. So I need to do a focused examination of your mental state, like how your mood, your thought process and judgment. After that, I will give you medication.
That's your time. Yep.
Okay.
Thank
How do you
you.
feel?
It's very hard.
Okay. What else? Why was it hard?
No, I don't know what to say. In the counseling, I am stuck.
Okay. It's
I don't
benzodiazepine
have a
so
sure. Yeah.
format, yeah. So have you
Yes.
sorry, just to ask, have you come across this case before?
No.
No, okay. And so benzodiazepine, alcohol withdrawals, alcohol dependence, recreational drug use, including heroin, are very common cases. Okay.
Okay.
Heroin, not so much, it's more methamphetamine, but you are going to see more heroin in your exams because there will be more heroin cases out in the community. It directly reflects. Benzodiazepine is a very common case. It's been coming in the last 2 months of the exam, back to back.
Okay.
Um, has anyone else seen the benzodiazepine case, like practice benzodiazepine case? No, no one has seen the benzodiazepine case and don't know have an approach?
No.
Susan,
Like
no?
I don't use, but
I have a brief idea about it.
Okay. Okay.
Yeah.
So if I was gonna so if I'm a person, so Susan, if I'm a person that's coming with benzodiazepine dependence, obviously he's dependent on it. What is a general advice in terms of can I get a script for benzos?
Yes, you'll still get a script of benzo because we cannot suddenly stop it. So we need to taper the dose before we stop. So the plan was to try and tell the patient that they will give them a script, but at a reduced dose, and then we're going to plan and see how we're going to stop it completely. And then On top of that, tell the patient that we can try other methods to help you sleep well because you need it every other day to sleep.
Good. So what's the difference? You guys have heard of oxazepam, lorazepam, diazepam?
Yes.
What is
Yes.
what is the
Yes.
difference between all three? Sorry, excuse me.
Duration of action, I think, or the half-life.
Yes, absolutely. So duration of action. So diazepam is a higher addiction rate because of the duration of action is long and it's one of the longest. And when diazepam breaks down and gets metabolized, it breaks into other benzodiazepine forms, which actually is an active metabolite. So you can have longer duration of action. So what we prefer to switch it to is oxazepam or lorazepam. Okay, which doesn't have an active metabolite. It's not a long acting, and it's easier to wean someone off of benzos. Does that make sense? So yes, you can have a script back, but I'm just going to change the drugs. Now, one of the things that AMC examiners look very much towards is the fact that when I'm re-prescribing the script, how long are you going to prescribe a script for? Anyone in the audience can participate. I would really encourage everyone in the audience to participate as well because it gives me an idea how much you guys know as well. So how long, so it's a 2 week period. So basically the candidate, you'll be having a follow-up. So we're just going to go to a quick approach because Sai, I understand you weren't actually familiar with the case, but so we're going to go through the case a little bit. Okay. Now, my format is that any substance abuse goes through there's a mnemonic. Does anyone know that mnemonic? For substance abuse?
So it's ask, assess, assist. Is that the one?
Correct, the 5 A's.
Yeah.
So what are the 5 A's? Can someone go through it really quick?
Ask, assess, advise, assist, and arrange follow-up.
Good. So I personally like to add one more to the A, in the first A, which is ask and appreciate. Okay, you got to appreciate the patient for coming. Otherwise, and that's how you build a rapport and how you kind of get your global score up. Okay, so Sai, you're my patient. Okay, so I'm going to be doing it this way. So, hi, Peter. My name's Priya. I'm one of the GPs I'll be looking after you today. Now, I see that you have come for a repeat script for diazepam, and you're usually on 5 milligrams a night. I see that you have trouble sleeping otherwise. Could you tell me a little bit about this?
Okay.
No,
Okay,
tell me.
I have.
Yeah,
Okay.
tell me. Tell me.
No, I'm stuck.
You're being me. Come on, go. All right, who wants to role play
I'm,
with me? So, Swarna, you go.
Yeah,
You know how to answer this. Go.
yeah. So, actually, I lost my partner, 3 months back, and I really needed this. This is what was keeping me going, and now I can't sleep without it. Just give me the drugs.
Swarna's going hardcore. I understand. I understand, Peter, and I know it's a lot to take in. Would it be okay if I can ask you a couple of questions, kind of understand you a little bit, and then come back and get back to you? Would that be okay?
Yeah, just give my drugs at the end of the day. That's what matters for me.
That's fair. Now, Swarna, I see that you're having trouble sleeping without it. Can I ask, are you getting a lot more palpitations or nightmares when you do go to sleep when you don't take it?
There has never been a day where I didn't take it.
Okay. But prior to this, like the 3 months before, have you had any chest pain, palpitations prior to going to sleep?
No.
Or is that what stopped? Okay. Are you having are you drinking before falling asleep?
I used to.
Okay.
Yeah.
And have you noticed any tremors or weight loss, unexplained weight loss or loss of appetite recently?
No.
Okay. First of all, I want to appreciate you for coming today for a repeat script. And I appreciate you for engaging with me to go ahead with this conversation. Whatever we talk about today will be just between you and me, unless it is harmful for yourself or others. Is that okay?
Yeah, thank you, doctor. I really appreciate it.
Yeah. So what did I just do? I appreciated her for coming, even though she's not looking to quit, right? And I am going to ask next is going to be, are you looking to quit? And I ruled out my organic causes, right? Thyroid, alcohol dependence. And then I went straight into my confidentiality statement. Do you see how I did that?
yes.
Now I'm going to see. Now, I do understand, Peter, that you need these medications and you're going through a really tough time. Are you looking to get off of the benzos by any chance and try other techniques?
Um, I don't know, Doc. I don't feel motivated enough to do anything now.
Okay, so that's ask, appreciate. Okay, that's your first day. I understand, Dr. Peter. I sorry, Mr. Peter. What we'll do today is I'll give you a bit of information about it, and then we can have another meeting to have a bit more of a chat as to how to go about, get tapering you off the medications as well. So today I do have a couple more questions. I see that you have been taking it for the last 3 months, and now the other questions I had, have you noticed that you're needing more pills, more than 5 milligrams to fall asleep?
Yeah, sometimes I kind of take two because all these thoughts get heavy in my head, and yeah.
And what happens? Have you ever tried not taking the pill?
Yeah, when I ran out of the pills, and that's why I came to you, I just couldn't sleep and I was feeling restless all the time.
Restless. Have you had any seizures or palpitations,
No.
excessive sweating, tremors,
No.
tummy pain, or diarrhea? No. When was the last time you took the dose of diazepam?
I think 2 days back.
Okay. And along with this, are you smoking cigarettes and vaping?
No.
No. Are you drinking alcohol?
Yeah.
Are
Once a while.
you, and how much are you drinking?
About like 2-3 drinks a week. Not much.
And when you do drink, how much though?
Maybe like 2-3 glasses of wine.
Okay. And do you ever binge drink?
No.
Okay. Do you do any recreational drugs, including marijuana?
No.
No. Are you allergic to anything?
No.
No. Perfect. And other than that, are you okay, amazing. And other than this, are you been noticing that your mood's been affected? How's your mood been in the last 2 weeks?
I don't know, I guess it's been a bit low because, I'm going through stuff.
That's great. And are you having trouble waking up in the mornings?
Yeah, it's more like falling asleep, and that's why I take these tablets. And then when I wake up, I don't know where I'm leading to. I just get on, by the day.
Now, some routine questions. Apologies. Some routine questions. Do you hear or see people the other people don't?
No.
Do you hear or feel things that other people don't?
No.
Do you feel like people are always talking about you?
No.
Do you feel like someone's out to harm you, or do you feel guilty about anything?
No.
Okay, good. And do you feel and apart from that, do you have any other issues, such as you said no to nightmares and palpitations, but what about, do you have any flashbacks or just anxiety to do things like the things that you usually do?
No.
Perfect. All right. And your bowel and bladder is all good?
Yeah.
All right. I think that'll be around 4 minutes. Okay. So did you see my approach was ask and appreciate, build a rapport. Then I went into my diagnostic questions, which is the dose, increase in tolerance, dependence, and withdrawal. Okay. Then I went into my MCH caps because the person's grieving, right? Depression wise. Then I went into my quick aseptic. But before that, I did do SADMAS because that SADMAS was in my differential diagnosis. But you can put that at the end. Okay. And then I was done. So that is actually the format of the benzodiazepine history. So ask and appreciate. Okay. Ask and appreciate. Confidential, ask a bit of organic causes, confidentiality statement. Then you're going into diagnostic questions, and and this is the assessment part, which is your tolerance, dependence, and withdrawals. Okay. Then you're going into your MCH caps, abseptic, SADMAs. Okay. And then you're done. You can even ask family history if you have time, because there is family link. Does that make sense?
Hey, doctor, can
Yes.
I ask you something?
Yeah, absolutely. Go.
Yeah, in the history part, do we first ask the open-ended questions or do we ask the leading questions as you asked? in the
Oh,
starting only.
open-ended questions from the beginning. So I asked, could you tell me a bit about your sleep? That is the only open-ended question I'm going to ask. That's when
So
she,
should it be, yeah,
yeah,
should
that's
it
when
be
she told me
about
about
this?
her passing, like her wife passing away. Sorry.
Yeah, all right.
Oh,
So should it be about the sleep or any of the problem that the person is having?
I'm not going to go dive into sleep hygiene just yet because that obviously it's not working, right? And
Uh,
obviously I need to
it's
recounsel, right?
working.
Yeah.
no, I meant like the first question, whether it should be like, how do you come here, or are you fine, or how can I help you? Should it be like this or directed towards the sleep only?
Okay. I personally, because of due to lack of like whenever there's a station that says 4 minutes and I know that there's a time constraint and it's limited, I try to direct the question more so like I see that you're having sleep, what the principal symptom is, and kind of ask from there.
All
An
right.
open-ended question with that. If it's a station where like I have 6 minutes or it's mainly history taking and then differential diagnosis, then I say, hey, how can I help you? I usually don't go with how can I help you because then they're going to tell you 5 different things and then you're going to be lost as to which one you're going to pick and go with. Okay, so I
Yes.
personally
Yes.
tend to try to stick with the principal symptom that they've come with and kind of say, can you tell me a bit more about this?
Oh, thank you.
You're welcome. Does that kind of help answer everyone's questions? Okay, good. All right. Now, Swarna, I'm here patient. So ask and assess is done. What's the next one? Assist.
Advice.
Yeah. And so now it's assist. What are the other ones?
Of advice.
Advice.
Assist and advice, right?
Yeah.
Cool.
Arrange
So,
follow-up.
and arrange follow. Perfect. So ask, assist, and arrange follow-up. Now, I'm going to ask. So, as
Advice.
yes. So now I'm going to assist. So now I'm going to ask. So, hi, Swarna. So, from what I can gather from today is, has everyone heard of the mind-body axis before I start? So that no one's lost. Has everyone heard of the mind-body axis? No. Has everyone
No.
heard of have you guys heard for psychiatry stations about normalization and rationalization? No.
I'm
Okay.
actually quite new to it, so
No, that's absolutely fine. If you guys heard it, it's good. If you haven't, and anyone in the group has heard about normalization and rationalization and has heard about mind-body axis, can you just put in the comment section, please? So it gives me an idea of how many of you guys know that. Okay. So in psychiatry, I like to normalize and rationalize. Why? Because I don't think anyone likes to hear that they're crazy. I don't know. Do you
Yes.
like to know that you're crazy? No. Right? So I like to normalize and rationalize. And what I mean by that is basically, Swarna. Okay, so I realize that I'm so sorry for your loss and that you recently lost your wife, and it's absolutely normal it's absolutely normal and it's absolutely okay to have sleeping difficulties, especially during this difficult time. And it can take its own time. However, it becomes a problem when you're having to take more and more tablets to actually get that good sleep, and you're starting to rely on the tablets. Are you with me so far?
Yeah.
So what's the difference, Rupa? You straight away told me that I was dependent on it, right? And I was in
Yeah.
denial that
Yeah.
I was dependent on it. This way, you kind of broke the news to me like I am technically dependent because I'm using more and more tablets.
Okay.
You're easing the diagnosis into the patient. No one likes to know that, hey, you're dependent on benzodiazepines because there's a social stigma to it. Does that make sense?
Yes.
Cool. Now, mind-body axis comes as a second statement. Now, this could be, now I told you, there's no confirmatory diagnosis. I have probable diagnosis. Okay. But this also could be that you're just developing a tolerance, that your sleep is actually getting more disturbed because your depression or your grieving process, your grief is actually getting worse, and we need to probably address that. You're probably having generalized anxiety disorder. I was thinking probably that you might be having features of generalized anxiety disorder. I was thinking that maybe you are having a bit of nightmares and anxiety, but you said you weren't having any of that. I was thinking maybe there could be some organic causes such as thyroid dysfunction or drinking just before bed that is actually affecting your sleep as a cause. But it's highly unlikely as you're not doing that, or it could be because you are drinking prior to sleeping. And apart from that, I was also thinking if you had, yeah. Do you see how I did the organic causes and I gave the differentials of other causes as well?
Yes.
Okay. Because you
Yes.
don't have any proof I'm dependent just yet.
Okay.
So indirectly you do.
Do
Does
we
that make
need to mention it in the counseling, all these causes? I'm thinking this and that.
Yeah. It's part of your counseling. It is.
Okay.
And if you don't mention it, it's a fail.
Okay.
Okay. And did you see how you kind of didn't stop and you were just giving me all the answers as to what the benzos was?
Yes.
It was like you were reading out of a script and you knew like this is the management, so I'm just gonna say it. I can't pass you now. Does that make sense?
So
Okay.
the diagnosis
Yes.
would be like dependence, or would it be like depression associated in
So
some, or what?
I would put this one, I would go with dependence because you didn't give me any other signs of depression. You gave me grief. You
Yeah,
did have a
a
loss.
good reason. Yeah.
A good reason, Liz, but I'm actually not as concerned about that as I would be You're here for scripts. So my most probable diagnosis is that you're probably building dependence or tolerance to the benzodiazepines and you're relying on that to sleep. But I was also thinking, could there be another reason why you're having to take this, such as organic causes? Maybe you're withdrawing from marijuana or alcohol, like because you're taking it just prior to bed. Maybe you're having an underlying condition such as thyroid disease, probably that we need to go look into a little bit further. I was worried that you're having generalized anxiety disorder because you did recently lose your wife, or you're having features of depression because you did lose your wife. Your mood has been low. And I was also thinking about that it could be you're having nightmares and palpitations that probably could be setting, or arrhythmias at night that's probably setting you off because you're night shift worker and you're sleeping at odd times. Does that make sense? And I was
Yes.
also thinking, could it be like other mental health disorders such as mania? But it's only highly unlikely as you're not having any other auditory visualization, you're eating and drinking. Okay. Does that make sense?
Yes.
Okay. Now, one of the main things is that I would like to do a multidisciplinary team approach, and that would be. So, are you with me so far? Do you have any questions? So then, Swarna, are you with me so far? Do you have any questions for me?
Doctor, will I get my script today?
Yeah, so we're gonna have a bit of a chat about that. So like I said, you have a mind and a body axis. Okay, so what happens is whenever you have anxiety and things, you depend on your. So remember, I tell everyone you need to draw for every case. It's not non-negotiable. So I say you have a mind and two circles align through it. And so you have a mind and a body, and they're connected through an axis. Whenever you have any sort of anxiety, grief, and all of that, it actually acts and manifests in your body. And that could be through sleep disturbance. And that's probably what you're facing at the moment. Okay, so as what we're going to do is we're going to have a multidisciplinary team approach. We're going to have a psychologist. And if you need, we can organize a psychiatrist. Me as your GP is going to be involved. We're also going to I'm also going to give you some information about sleep hygiene techniques. And if you need any other assistance, I can arrange for that. He doesn't need any dietitian. He doesn't need anything else. I'm just going to leave it at that. Does that make sense?
Yes.
Okay. We're going to have a multidisciplinary team approach, but to start off with, we're going to have a non-pharmacological, we're going to have investigations for some bloods to make sure there's no other organic causes kind of setting you off. So it's just a full bloods, UECs, your thyroid function test, your liver function test, because you do drink, and make sure there's no sort of infection that you're having, such as a CRP. And once that is all done, and I'm also going to do vitamin B12 and folate levels as well, because you are consuming alcohol. Apart from that, what we'll do start with a non-pharmacological therapy. First of all, we're going to start with SNAP. Like you snap your fingers, SNAP. So first of all, we're going to talk about quitting in our next meeting, but that is something that we're going to be looking at. And then try avoiding alcohol before bed. Try avoiding alcohol early mornings. Having a good nutritious diet, like having a high fiber diet and a healthy diet with low salts, low fatty food, and exercise. 30 minutes a day, 5 days a week, ease yourself into it. I know it's really hard, but you can definitely do it and it'll definitely help with your sleep. Are you with me so far?
Yeah. So you're not basically telling him a no, or you're not telling him a
I'm
yes.
not. I've not told him
You're
a no.
being very diplomatic.
I am.
Yeah.
And then I'm going to give you some sleep hygiene techniques. So this space, I have a list. I'll be printing it out for you so that you can follow. But main things address is that you don't have a heavy meal just before bed. Try having a meal 2 hours before, exercise 2 hours before bed. Not 2 hours, within the 2 hours. You can have sex with your partner, which does help, protected sex. I also advise for like a night, don't shower just before bed. 2 hours before, have a nice warm cup of milk before bed, so that you don't feel hungry at night, and start with
Same,
that. Yeah, and we'll
same.
start with that, and I'll give you more reading material about what sleep hygiene is. And apart from that, we could also, if this is not helping, we can also arrange for some talk therapy as you recently went through. Give them a reason. Don't just say talk therapy. Like you went through talk therapy because you recently lost your wife, and that is a huge ordeal to go through. Are you with me so far? You see my expressions? I'm actually being empathetic.
Yes.
Like it's a huge ordeal to go through. I'm
But
really sorry.
yeah, one doubt, like practically talking, can we send him with a script, because you anyway can't like suddenly cut him off the
Yeah,
drug.
absolutely. That's what I'm getting. Yeah.
Theoretically, you have to like maybe send him with a script and
Oh,
just say,
yeah,
like there are two parts to it. One, you can stay on these drugs knowing all the risks. The other is we can work our way together to reduce these
No, I will never be giving him, no, no, no. I will not be giving him the option of staying on this drug.
Okay.
That is not right. So that is against our CGP. So the strict guidelines is so now let's talk about benzodiazepines, Peter. So as you know, there are other forms of benzodiazepines, and ideally, what we prescribe and we're allowed to prescribe is that it's usually for 2 weeks if it's for sleep. Okay, and it's only to be taken as needed when you've exhausted other forms. And usually benzodiazepines are not your first line medications. Okay, so what I'm going to do is definitely going to give you a script, but I'm not going to give benzodiazepine is a long-acting drug, so I'm going to give you or switch you to another benzodiazepine, which is a shorter acting, but has the same effect for you to fall asleep, but not maintain the sleep. Does that make sense? Okay, but apart from that, we're also going to try other medications. Anyone know what it is? He's 52. Anyone from the group can answer as well. What other drugs can we give him?
SSRS.
Nope. Over the counter.
Melatonin.
Melatonin. They could try melatonin. They can also try some magnesium. So 30 minutes before you go to bed, having a melatonin or some magnesium can also help you as well, and not be dependent. So what we're gonna do is I'm gonna give you a script for the benzodiazepines, but probably oxazepam or lorazepam. It's a shorter acting. And I'm going to give you I'm going to start giving you the medications where we're going to titrate the doses down. We're going to start slowly weaning you off over the next 2 weeks. Are you with me so far? You don't need to really specify what benzo. You could just say shorter acting benzo. Okay.
Usually temazepam.
Or temazepam, absolutely. Even people get Loraz as well, so either one is fine. And you say what we're gonna do is once you're weaned off, we can start you on melatonin, and we can try other medications, such as melatonin and magnesium. And if you are having depression and and some sort of mental health contributing to this, we can consider mirtazapine, which is another SSRI. Are you with me so far? Do you have any questions? No. I'll give you some reading
Anything else that I should know, doctor?
The only other thing is that you cannot mix alcohol with your medications. That is absolutely a no-no, because you can overdose. And I'm going to give you reading material, and you can come and we're going to make a follow-up appointment with this. Are you with me so far? Any questions?
So alcohol and benzos are a strict no-no, right? Like
Absolutely. Absolutely. No mixing benzos and alcohol. Okay? Does that make sense? And the reason this case is
Yes.
coming for you guys is we just intubated 2 people just last night for this. So it's a very common thing. Yeah. Both of them intubated back to back. Okay. So and that's just one hospital. So it's very common and it's a very common case that comes all over Australia. So that's why they're trying to give you that. Okay. And I've actually reported a GP for prescribing too much diazepam. I had to. Otherwise, I'll be fined. Does that make sense?
Yes.
Okay. The other reason they kind of putting this case out for you is because benzos has a high street value. So people come to you for benzodiazepines to sell them in the black market. Okay?
Okay.
They have high street value. Cool. All right. Next one. Sai, do you understand that case? How to approach it? What to do? Do you understand the structure of approaching the case? Anyone have any
Yes.
questions of benzodiazepine? Because it's an absolute, like it's a common case. Had in June, July. It's coming very regularly. Anyone in the audience as well, please.
I would suggest you just practice it out because you would have all the information, but it's very
But I'm
difficult.
not.
Yeah, when you're stressed, it's very difficult. So it
So did you see
doesn't
the
just
difference?
come up.
Yeah. Did you see the
Yeah.
difference when you actually had to role play
Yes.
it and how we actually knew the case? It was difficult, right? And that's why a lot of people fail
Yes.
the.
Yeah. And you just have to start somewhere. Start role playing.
Yeah.
That's how you
Any
head to the next.
questions? Any questions?
No.
Yeah.
Cool. On that
Okay.
note, let's progress. Next case is who do I have? I have Susan. You're next. And you're with
2 seconds.
Liz. I'll do the timer.
Yeah. Okay. I'll move the case. Yeah. Okay. There you go. Station 2.
All right, stop.
Mm.
All right.
Time is up.
Time? All right, go.
Hi, my name is Dr. Susan. I'm one of the doctors here at the GP practice. Nice
Hey,
to
nice
meet you,
to meet
Emily.
you. Me too, Doc. Nice to see you.
Yeah.
Can you hear me? Nice to see you.
Yeah, oh, thanks for coming in. So I understand that Tommy has been constipated for the last few days, and
Yeah.
you've told me that I can see that the medication that there's nothing has been found that to be the cause of his constipation. Can you tell me more about it, please?
Yeah, it's been going on for a while now, Doc. Like, I don't know. Sometimes Tommy is here. Like he tend to have this constipation going on for a while now, maybe like 2 or 3 months, I guess. But this time it's really hard. He has been complaining of tummy pain a lot, and I don't know. It's been very difficult. We have tried some syrup kind of a thing. I don't know what the name is. It starts with M or something, but then nothing works. He's just constantly constipated.
I'm so sorry to hear about that. I'm sure that's very concerning. I'm going to ask you a few questions and we'll be able to figure out what's happening to Tommy. Is that all right with you?
Yeah, yeah, sure. We really want to know what's happening and how I can help him.
So you say the constipation has been there for the last 3 months. Yeah. Has he like how did it start exactly?
I mean, it's not like last 3 months, but this concern has been going on and off, like, but since last 3 months. So this one, I think it started like maybe 5 or 4 days ago, and then he has been not opened his bowels.
Okay. Okay. So when it started, was he at school or was he at home when this concern started?
He was reluctant. I would say he might have had way before this, but he was like reluctant to let me know what exactly, because he's only 5 years old. He doesn't understand what exactly is happening. But then I don't see him going to toilet, and he's going to school. He's just started his kinder, and then yeah, I don't know if he's going there. I don't think so.
Okay. And when did he start going to kindy?
Maybe last year.
Last year. So for the last year when he was going to kindy, was he all right or he had these issues of constipation?
Started telling me only since last 3 months.
Okay. And has he been toilet trained?
Yes, he is. He is.
Okay. So by the time he was going to school, he was well toilet trained, right? Okay. And are you able to explain to me exactly what you mean by constipation? Is it that he's not able to open his bowels, or is it that he's passing hard stools, training to bring to
Yeah, so
school?
what happens is I don't see him going to the toilet. I ask him to go sit for like so long, and then he doesn't pass. And he will be like, I can't do it. And then he comes out.
Okay. And how long does he go to sit in the toilet before you actually let him come back?
Oh, I don't know. He might be sitting there for like an hour or something.
Okay. And you've also said that he's been having abdominal pain. Where exactly is the pain?
It's it's right there because he wants to go, but he's not able to. So I know that that's what's happening.
Okay.
That's why it's tummy pain, but nothing serious.
Okay. And can you please tell me more about Tommy's diet?
What would you know? We eat
What
everything.
does he normally like? What's your regular diet of composed of? Like, what do you normally give him on a daily? Like, let's
Yeah,
say in the last week.
I try to give him everything. We could like what we normally eat, like it has veggies, but he's not fond of veggies like every other kid. He's not. So he just eats meat, and he likes to drink a lot of milk. He has like a lot of cow milk, I guess. Like he loves milk. So always he have milk, but he doesn't like to eat veggies and things like that. Yeah.
So just confirming that he does not take vegetables. And what about water and high fiber diet? Does he also take that?
I don't know what high fiber diet is.
Um, like let's say grains. Does he take that also, or he doesn't
I
take
don't
that?
know. No, he's not interested in all that.
Okay, that's okay. And okay, that's okay. And um and how is the situation at home? Does he like staying at home or he likes going to school?
Oh, he has mentioned sometimes that the kinder is not that clean, so he don't like to go there while he's inside the kinder. So
So you say that the toilet at schools are not clean, or what? I didn't get that,
I
sorry.
think so. It's not clean. Yeah.
Oh,
So
okay, okay.
to come and he comes and tells the kinder, but he loves to go to meet his friends. But this thing I know he's having finding in trouble. Yeah.
Any bullying at school?
I don't know. I
Okay,
don't.
it's not told you that. Okay, and so this constipation, is it more when he's going to school during the week or also on weekends when he's staying at home or during school holidays?
I've seen it more during weekdays, not weekends. Yeah.
Okay, and any new thing that has happened? Because you said for the last few days it's been worse. Any new thing that has happened to him?
No, nothing.
Okay. Okay, and how is birth history? Was he born term, preterm?
Yeah, he's good. Healthy kid, no worries. Everything good. I've been immunizing him. All good.
All immunization are up to date. Any regular medication that he's taking?
No.
Okay, and are you happy with his growth and development so far?
Yeah, I am.
No issues with his growth and
Only the
development?
constipation. This is the only trouble we have,
Oh,
you know? Yeah.
okay. And have you got support at home?
Yeah, we have like good support. Yeah.
Who takes care of him at home?
Me, my husband, and my grandparents, his grandparents. Yeah.
Okay, okay, thank you so much, Miss Emily, for the information that you've given me. So from what I've found out is that I think Tommy might be constipating with the fact that he's only taking a lot of meat and he's also not taking vegetables. So when we take vegetables, vegetables contain some fiber and water in it that will really help make the stool soft and make the stool come out. But if he's only taking meat, it makes the stool really hard. And sometimes when he's passing the stool, and sorry, before I continue, have you had any blood when he's passing stool or any pain when he's passing stool? Has he complained of anything of that sort?
No, but what do
Yeah.
we do about the situation now? He's constipated. Are you going to give him something like last time when we came, some doctor gave him some enema? I think so, like something behind his buttocks. So
Yes.
are we going to do that now?
We're going to discuss and we'll be able to come up with a possible solution that will help him so that in future this does not happen. So
Yeah.
basically what is happening is he's not taking enough fruits and enough water. So it makes the stool really, really hard because when the stool stays in the stomach, most of the water is reabsorbed back and it becomes really hard. And so passing the stool becomes difficult. So what we might have to do is we will come up with a diet plan for you. If you can try that every other time he's having a meal, make sure that he's having a lot of fruits and a lot of vegetables in the fruits. And then is that we can try and probably make different shapes of the fruits. Probably do some color, put some food color so that it can have a nice appealing color and he might be able to like it. Yes. Are you
Okay.
with me so far?
Yes,
Is that
yes.
something that we can be able to try at home?
I'll
Yes.
try. I'll try my
And then
best.
also we want to also increase his water intake. Just make sure that with every meal he's taking in enough water, and also in between meals you have some water to give him afterwards. Yes. And then maybe we can also try and reduce the
Time.
milk that we're giving. Time
Okay.
is up.
Good
Yep.
work. Sorry. Yeah.
How did you feel?
Um uh how I felt. It's like okay, I think I was quite comfortable because I was able to point out what was the cause of his constipation. So diet was the main thing, and then also there was also some aspect of school that this was only happening when he was going to school. So there were some things that were affecting him at school, and it looks like it started when he went to school, but the mother was not able to come up clearly and tell me that this started exactly when he went to kindy. She was not giving me all the information I required. My thoughts, yeah.
Okay. So you spent you spent 6 minutes on history overall. Okay. And I couldn't stop you because it's not a time station. So the examiner won't stop you. So just guys, just to be careful, not every station, they're going to have a time for history. Okay. So going back to this, what is your differential diagnosis? And I kind of picked out a couple. So I'm just going to tell me what were your differential diagnosis for this person who's having constipation. What do you think a 5-year-old boy versus a neonate having not a neonate, an infant having constipation? So what are your differential diagnosis for this case?
Um, Bullying at school,
Is that the
some
first
social
one? Is that the first on the
diet.
list?
No, the first on the list is diet.
Okay. What about the diet?
Low fiber diet.
Okay.
I don't know if not taking water is also a differential there. I'm not so sure if I'll put it
Yeah, so
there.
kids that start school, their eating habits go. How many kids actually go to school and finish their lunches and come back? The entire heat, gone from eating 3 times a day, full meals, well balanced diet, to going into meals that are altered, where they drinking less water, less fibrous food, less veggies and fruits in their meal plan sometimes, and then they're going down, right? So that definitely. So diet, you're mainly thinking about you simple things first. So that is a high fiber diet, and your water. Then you're going to go down the track of milk.
Yeah.
Yeah, no problem, Purva. That's all good. You have the sixth case though, yeah.
Yeah,
Um,
I will try. I will try to rejoin,
yeah.
but actually my visa process is ongoing, so I need to go. I'm
No,
so
no,
sorry
no
for that.
problem. No. It's
Yeah.
all good. All good.
Okay.
Was this
Thank you
helpful?
very much.
Is this helping? Was this
It
helpful?
was very, very helpful. I
Okay,
will try to rejoin as soon as possible. Yeah.
good. Okay, so so
Thank you.
that's your first differential. Now, main thing that you need to remember in ANC, all life-threatening conditions need to be ruled out first. So in a 5-year-old boy's constipation, it's not a sudden onset, but it's a sudden worsening of constipation. Can someone, if you guys give me differential diagnosis?
Intestinal obstruction.
Yeah, cool. What else?
Um,
Anything else?
Uh, Mesenteric adenitis, diverticulosis, diverticulitis,
no, I
and IBD.
RAG.
Diverticulosis, diverticulitis is this age group?
No.
no.
Mesenteric adenitis is the age group.
Yeah,
Mesenteric
mesenteric
adenitis,
adenitis.
is
Yeah.
it constipation or diarrhea?
Diarrhea.
Diarrhea.
Usually they come with nausea, vomiting, and tummy pain, right? Like,
Tummy pain, correct.
yeah.
Dr. Bhagat, can you tell me, I will take celiac, IBD, IBS, what's the difference? Someone tell me the difference.
Autoimmune, and I think one is stress related.
Correct.
IBS related.
Correct. So IBS is more so stress, IBD is actually a thing. And does it come in this age group?
No.
No. What else? Thyroid also unlikely. What is that? What else is common?
Cow milk protein allergy?
Cow milk protein allergy, good. What else? Because and also lack of food, right? Because he lists that he's drinking lots and lots of milk, right? Instead of an allergy, it's more so the fact that he's having too much of cow milk protein. Okay, so the CMPA is mentioned by Dr. Bhagat, but more so there's too much cow milk. That's not a well balanced diet. All right, perfect. And you said bullying. NAIs. You guys have to consider non-accidental injuries in this case. Okay, you missed that. It's a big no-no. Suddenly the child is not pooping. It can have all those other issues. Trauma is important. If the child's fallen, had a back injury, can that affect bowel bladder?
Yep.
Yes, spinal trauma. Always, please do not forget your spinal traumas. And other ones, he's too old for Hirschsprung's and meconium ileus and all of that. Celiac is definitely cystic fibrosis goes with that as well. Okay, any primary ciliary dyskinesis also goes with that. Does that make sense? Cool. So
Yep.
in this, and last but not least, guys, 5-year-old boys hernias. Very common case missed. Okay, so please don't forget your intestinal obstruction. Hernias, not diverticulitis or osis, but mainly hernias are something that you can't miss.
Can
Is
fissure
that clear?
be differential in this case? Anal
Yes.
fissure?
Anal fistulus, he's too old for perianal fistulus.
Yeah.
He's too old for perianal fistulus. Does that make sense? Okay, I've sent you guys a PCH guideline list. Okay, so you did, Susan, to be honest, your history taking was absolutely beautiful, but just needs to be a bit more concise and a bit more shorter because you just don't have the time. Okay, so onset duration as is progressively been getting better and then is associated. Now, the other things are my go-to are fevers, weight gain, weight loss in terms of a thyroid. What is your diet? You got to the diet part really late. How many times is diet as connected to your poops? Very common, right? Especially in these kids, right? So that's very important. And then you went down to the psychiatry history, but the only reason you didn't get too much of psychiatry history is because you didn't mention confidentiality statement.
I get it.
Okay. So
Yep.
you said the mom wasn't clear. Well, you kind of didn't give her the reassurance of confidentiality statement. Like she's not going to say I abused my child, you know, just out in the open. So just make sure that you're not missing that because that's a red flag. Okay. So a person who does a case so well, I still can't pass you if you haven't checked NAIs. Does that make sense? So this is
Just
another why
Yes.
kind of
something onto that because before I forget, I did say Tommy is with me, but in the exam, Tommy won't be there. But then I am talking about a constipation of my child in front of you. So you did not show me any empathy of that's why I was not able to like give you more, you know. You are, oh, it's very, I know it's very difficult to ask you these questions, but is it all right if I ask those things? Because they're embarrassed and they don't usually understand. Even if I say 3 months, it would have been going on for a while because 5-year-old don't understand how to tell that I'm constipated, right? So this is exactly was a case that came in ED that I saw like few weeks back. This is exactly how they talk. Like they are very reluctant to talk to you regarding constipation, and sometimes they just are too much focused on what you're going to do now rather than giving me dietary requirements or what to do about this one, right? So that's one thing regarding constipation. Just wanted to let you know.
Thank you.
Can worm infestation would be a differential?
worm infestation can be, but doesn't really cause constipation. It depends. Roundworm causes anemia. Hookworm causes anemia, which is not really common here. The main common worms that you find here are pinworms, which just cause irritation in the perianal region. And roundworms are also not common, more so it's the other worms that are common here. So it wouldn't be on the top of my list. But the other thing that needs to be on the top of my list is behavioral. Because Liz did say he has been suffering from constipation for a while. So he's just traumatized from the painful
Sitting
defecation.
on the toilet seat, yeah. Holding for long
Correct.
duration.
Yeah.
Holding
So the other thing, they exploring one more thing was because the kindergarten toilets were not clean, he might be holding for a long day, and then that became a behavioral thing. So I wanted you to pick up on that too sometimes. So the follow-up question that I did in this case when this happened in ED was I asked like, have you talked to the authorities about clean toilets? That's like more of like a conversation. You are asking the mom about, have you talked about the authorities? So that's one of the other management part, like you're getting involved, you know, that the kindergarten people can clean yeah.
Yeah. Mm-hmm.
Okay. So going
These
back,
are
so yeah.
yeah.
Sorry.
No, I was just telling this, these are brownie points, something out of the box. You have to think out of the box. It's not about you saying like, this, and this is there. It's becoming a conversation and there. That's all. You have done it beautifully. It's just that counseling cases are a bit different as to why you're not passing. It's about the brownie points here. You can pass if this was a medicine station, you will pass this case. But once it comes to counseling station, you need that brownie points. You need that, extra points to pass that. Counseling is difficult in that way. Just to tell that. Yeah. Okay.
Yeah. So the other thing is you did Bindsma really well. Immunization history was not taken though, which is not okay.
She volunteered. She said child is immunized. Was I supposed to ask?
Oh, okay, that's fine then. Up to date. Just say, is it up to date? There's a quick question. Is it up to date? Okay.
Yeah.
And then confidentiality statement in your family history. That was pretty much it. The other thing you started. So let's just run through your counseling station really quick. So in counseling, you're gonna still do investigations. You're gonna have multidisciplinary team approach. Okay. So it always starts with. So my most probable diagnosis the child has constipation and most likely due to in her case it was a combination of diet plus function plus behavioral, right?
Yeah.
in her case. But I was also thinking of other things, such as could there be some underlying conditions such as celiac disease, which is basically allergy to intolerance to gluten, too much cow's milk protein, thyroid issues. I was also thinking that could there be any sort of a behavioral component to why he's being constipated? And also, could there be a bowel obstruction, which would be a medical emergency? That actually should be in the beginning of the thing, but it's highly unlikely as he's not actively vomiting and he's still eating and drinking well. Okay, so
Yeah.
you guys know about the well baby questions, right? What are the well baby questions?
Eating and drinking well, alert or drowsy, decrease in wet nappies, and pooping well or not.
Yeah, so and this is not pooping well, but did I hear about lethargy and did I hear about
Yeah, alert and drowsy. That's
that is yeah. Cool. So that's the main thing. And then last but not least, okay, cool. Now, well, baby questions. Then after that, so you're going down the path of management. So management, you've broken down, you've given the differential. So it's the same structure, guys. Probable diagnosis, differential diagnosis with reasoning, okay? Then followed by multidisciplinary team approach, okay? Then followed by investigations. What investigations are you going to do for this person?
I think
Anyone?
like no need at this stage because we know it's just constipation. We have to try our methods like fixing the diet, putting them on Movicol.
But if any of the red flags, such as weight gain's not there, okay, weight loss, if the child is in distress and pain, if the child is having any sort of, and if it's a neonate or an infant, if less than 6 weeks of age, delayed passage of meconium, and if the child has persistent vomiting, in any vomiting case, you have to do bloods. Okay, only when everything is ruled out and NAI is ruled out, then you don't need to do bloods. Does that make sense, guys?
Yeah.
Okay.
What
So what?
specifically in bloods are we looking like for anemias or
Correct. Great question. And in his case, in this case, it'd be anemia because he's drinking a lot of cow milk. Does that make sense? A lot of cow milk, a lot of less high fiber diet. So, and also I'm worried about celiac. So I would do investigation on this boy because he's just acutely worsened. Does that make sense?
Yes.
So, Dr. Bhagat, you're absolutely right, but your first investigation was stool MCS. How easy is that going to be to get? Are you there? Are you able to turn on your camera and your thing? Sorry. And where are you?
I can see it, but I don't think
I can't see her.
it's there right after Disha. On that point, one other thing, what question do we ask if you want to rule out intestinal obstruction, which you missed? That's one other thing you should ask.
Vomiting,
And
abdominal pain, vomiting.
and complete obstruction. What happens in complete
Oh,
obstruction?
they're not passing flatters. Oh my God. Yeah, I forgot. Yeah.
You should ask that. Like,
Yeah.
I was
Yeah.
looking for that question. Is he like constipation? I can understand, but is he passing wind? That's one thing. That's major thing
Oh,
you
yeah.
should rule.
Cool. So main thing is that, and you never do stool MCS as first, so you have to organize it. That's another reason a lot of candidates fail the exam. So you're going to do it full blood, full bloods, UECs, making sure you sent for a celiac screen, which is a TGG, the immunoglobulin test, thyroid function test. You're going to also send what else? Iron levels, vitamin B12, folate levels, vitamin D levels, right? All the essential amino acids and fats. And then you're going to go down the track and iron levels. And then you're going to go down the track of, because what does a celiac disease present with? Iron deficiency, DEEK, all the essential vitamin deficiency, and
and Symptom wise, or you want like system?
System wise.
Mm.
So, and essential fatty acids. Okay, because it has to be eaten, okay, and absorbed. So, and also your vitamin B12, folate, you'll check. So, does that make sense? And then you're gonna go down the path of stool MCS. Okay, then you're gonna go, and not just stool MCS, you can all you there's also tests for celiac disease in your stool sample. Everyone knows that as well. What is it called?
Something globulin. What is?
Yeah, what's the celiac test done?
And cardio something.
Huh?
Something globulin.
Transglobulin. That's in your blood test, right? Stool sample, what will I find? What will be different the stool sample in celiac disease? What happens? Like, what is the character story that the mom gives you about the stool sample?
Sticks to the pan. It is
bulky and
greasy, so maybe the fats in there.
So just find that out. Okay, so serum TTG is your celiac disease, and your but the history of how the stool is important. Okay, cool, perfect. So the going down, so you got your good set of differentials. You've got your investigations that you're gonna do, and then you're gonna go and you're gonna try to get a bit of urine as well if he's developing. Because have you heard like kids can't pass urine well because it bowels so like it's pressing on the ureters or on the bladder itself because they're fully impacted. So that becomes an issue. And then in terms of management, are you going to have multidisciplinary team approach? Who's going to involve in multidisciplinary team? Any idea?
Psychiatrist, because he's going.
Is he the first person? Who else is going to be involved?
Pediatric. No, no need of a specialist.
Dietitian, pediatrician,
Dietitian, pediatrician, pediatric gastro. Who else?
Endocrinologist.
Yes.
Endocrinologist, yes, absolutely. If it's going down that path, what else? Who else?
The teachers at school, I think. School.
You'll liaise with the school, but GP, guys, don't forget your GP, your good old GP. Okay, don't forget your good old GP. And if there's a bit of a social work issue, then if there's a bit of a stress at home, then social work as well. Okay, cool. In terms of your okay, cool. And then apart from that, non-pharmacological method. What is a non-pharmacological method?
dietary modification,
Like what?
increasing dietary fiber.
Like add prunes or peaches. They have more fiber, and whole cereals. Avoid junk food.
But make it interesting. Like, tell me, Swarna, tell me. How are you gonna tell me as a mom? Go for it.
What I would highly encourage is change the
Wait,
diet.
let me set the setting.
Yeah.
Doctor, I'm really worried that he hasn't opened his bowels and that he's gonna get really sick and that there's something really wrong with him because I Googled it and I'm just really, really worried.
I can understand you. It must all be very overwhelming. Don't worry, I'm here with you. We're going to make a plan for him. I'm sure, like I have ruled out all the other dangerous causes. I know it is overwhelming and to read all those stuff also on the internet. But according to the history and whatever I gathered today, I have ruled out all the serious causes of constipation, and definitely I'm sure Michael doesn't have any of those. What he has is a constipation because of poor diet and also some stressors that are bothering him. So we will address that one by one. We will work as a team to help him in this condition, and we're all with you in this. Okay, so first we'll work on fixing his diet. We're going to you want a tissue? I'm here with you. I can understand being a mom is not easy. So, we will work in this together. You don't have to be worried about anything. Okay, unless he's playing well, he's eating well, and he's being alert, you don't have to worry about anything. Okay.
Okay, so now how can I fix this now?
Yeah. So we will, work as a team. First, I will be assigning a dietitian for him. He will fix the diet, make foods which look interesting for the kids, just
So, sorry, now one thing to
Mm.
say. Susan, you can't say add food coloring.
Mm. Okay.
Yeah, it's a no. Okay, so
Yep.
no food coloring. Okay, what else? Yeah, just by saying that I had to fail you just because you said that. You actually did the case really well, but because you said
Okay.
food coloring, I was like, oh no, crash and burn. Okay, cool.
Yep.
Okay, yeah, keep going. Sorry.
Yeah, first we'll try to fix his diet. We'll make sure how interesting his food can be. Like, we'll try to add lots of veggies and just intrigue him into healthy food. And
How? I don't know how to trick him into healthy food. He hates all veggies. He just wants nuggets, chicken nuggets, and chips.
maybe like shape the veggies in his favorite shapes. Like, if he loves space, make like star, star, whatever you say, like make them into stars and moon shapes, just make it interesting. We can work with this.
Yeah, so
So,
basically you're gonna say instead of adding food coloring, you're gonna say you're gonna use bright colored food like carrots and
carrots, beetroot.
yeah, cucumbers that are bright color that catches eyes. And you're gonna try using to make it easy and quick, Swarna, because you're losing a lot of time, right?
Mm-hmm.
Say, all right, so first thing we're going to try without any medications, and that is basically adjusting his diet. And that's going to involve using bright colored food and using a lot of fruits and veggies and lots of whole cereals. And when you're using the whole cereals, try avoiding any artificial coloring and try using natural colors and using bright colored fruits and veggies. And try leaving it out there. Don't force him into eating anything. Keep a glass of water with him whenever he's drinking, eating, and making sure that he's up to date with his water intake and making sure that you kind of make it interesting with his eating. Try cutting them into shapes and sizes and maybe adding a little bit of and making it interesting while he eats. Try avoiding any TV time when he's eating or being distracted when he's eating. And other than that, you
Let him eat on his own, explore his own food. Kids
correct.
love playing with the food. Yeah.
Try using different textures of food and let him
Yeah.
eat on his own. Do
Yeah.
not force him and do not
Do
and
not
let
overfeed him by chance.
as exactly simple as that. Yeah. In terms of him, his behavior side of things on the stool, let him just be on the stool for 5 minutes. If he doesn't do it, just get him off. Don't force him to be there longer. Don't make him sit for prolonged periods of time and try and strain.
Do
Just
we suggest the stool, the high stool,
yeah.
just to
So
make
make
the legs
correct.
flexed?
Legs flexed, so you using an adequate chair support for him to sit where his legs are flexed at a 90 degrees, so he's sitting well in the chair and his tummy is nice and soft. Not more than 5 minutes. Get it if he's pushing, he's giving it a good shot. Positive reinforcement, a lot of encouragement, and get him off this. And you try just intervals, like try in the morning, try again in midday, then try again in the evening, then try again at nighttime, and then keep going. Okay. And a lot of positive reinforcements. And try making it a routine. So every time he wakes up in the morning, then at this time, then at this time, and then at this time around his schedule. Make it a routine and don't go out of routine and proper positioning. Okay. And then apart from that, you're also, and if he has a sibling, try doing with the sibling to encourage him, making it into a game to make it interesting. Main thing is not to make it judgmental, and keep going from there. In terms of his medical management, if he's still having a lot of trouble and he's having tummy pain, he's very in a lot of discomfort and his urine output is gone down, we can give him some medications for disimpaction.
So Movicol is something we use it chronically, we taper it down, right? Like
Correct. But before you can give Movicol, how does Movicol work? Does anyone know how Movicol works?
it's a laxative, right?
Yeah, but what kind of laxative?
Osmotic?
Yes, correct. It's an osmotic, what we call move the colon. So it's like it's an osmotic laxative. But what is happening to this child if he's been blocked up? What's going to happen to him? Is he going to be blocked up top or down below?
Maybe down below.
Correct. So even if you give up top, it's not going to really disimpact from down below, right? So you need to disimpact and then put him on a Movicol regime. Does that make sense? So just going on to Movicol regime is not going to help. Does that make sense? And you never, ever in a million years, in your entire life, ever, ever do a perorectal exam. Ever.
Just
Never.
just inspect, not yeah.
Ever.
Yeah.
Okay. So please, that's a straight fail. Okay. And it's also harassment. So please do not do what do you call a perorectal exam. So first things first, you're going to, so if it's an infant, right? What's your laxative of choice? Coloxal. Okay. Coloxal. And if the child is that's less than 1 month, sorry, 1 month to a year, you can give osmotic laxatives, okay, like such as Movicol, and you can give lactulose, okay? And then apart from that, more than children, you can give Movicol laxatives. But main thing to give is disimpact from down below, which is glycerol suppositories first, okay? So glycerol suppositories, and you're going to put them on a Movicol regimen. Okay. Main thing is I'll print it out for you on how I'll print it out for you and I will tell you what the regimen is. Main thing to consider is once he's opened up his bowels and he's opening it very comfortably, and you need to stop the Movicol. Like you taper down the Movicol regime. Okay. You don't keep going for the whole course. Does that make sense? Because what happens if you go for the whole course?
Big diarrhea, basically.
Yeah, basically. It's gonna come out of the other end. And you'll be surprised how many people actually come to the ED saying my child has diarrhea, and then you find out that they're on a Movicol regime.
Yep.
Okay. So it's very important to tell the parents what to look out for because they're first-time parents. So you say, once the stool starts becoming soft and he's able to open it without any pain, you're gonna start tapering the Movicol doses. Is that clear? Cool. Perfect.
The common question from parents is, will he get addicted to Movicol?
Yeah, that's a very good question. And the answer is no.
No, yeah. So, but each and every parent asks if the child will get addicted to the Movicol.
It's a very common question. And I understand where the thing comes in, the gut being dependent on the laxatives. And also to understand that do not restart these laxatives right away if he goes constipated again. That's the other thing to kind of counsel them on, just to make sure you wait, you only start it if he's actually in discomfort and you've tried all the behavioral therapies, like all the non-pharmacological methods. If they have all failed and he's in discomfort, then you can start it. Restart. Does that make sense? So you have to kind of advise on that as well. If he's like vomiting and stuff, you got to be careful about that. Last but not least, try to make him not dehydrated because you're giving him Movicol. He's opening up his bowels. Make sure he's still staying up on top of his fluids and also continuing to get more fluids because he's going to be opening his bowels and having a bit of runs. Clear? Because they can have overflow, right?
Yeah.
Cool. Is everyone with me so far? Any questions? No. Okay. And last but not least, you can, and last but not least, you are giving some reading material. You're giving the 5 R's. If he's, and what are the red flags? Vomiting, lethargy, bloody stool, ribbon-like stool specifically, right? Ribbon-like stool. Sudden onset of severe abdominal pain. You come back to us right away. Clear? Very complicated. Like I know that necrotizing appendix can actually cause constipation as well because the bowels become aperistaltic. Does that make sense? Cool. Any questions regarding this case now? No?
Yep.
Cool. I've given you guys a reference for PCH guideline. Please only follow that guideline. Please do not follow any other guideline. Okay? Cool. We actually print out the PCH. There's a parent sheet for PCH constipation as well. It's a great one that we always.
Yeah, I have pasted the parent sheet in the the
Yeah.
kids
Uh,
info in the chat, because usually we take the printouts of the kids' health info and then print it out and give it to the parents. So it's
yeah.
written. How long will the session last?
Sorry.
Yeah, I mean, there is a question in the
Oh,
chat.
we're gonna try. We're definitely wrapping up by 4 because I have to pick up my daughter. I promise. All right, cool. Now we're gonna move on to next case. Who's next case?
Mine.
Verna, yes. Okay, let's go.
Oh, wait.
Are you doing this one,
Oh,
Liz?
no, you can do it. Like I'll
Sure.
do the timer. Yeah.
Cool. Go.
It's still at station 2.
Yeah. I haven't
Oh,
taken the
okay.
sorry. Okay. So you're ready, KP?
Yeah.
You're ready?
Yeah,
You
I'm ready.
ready? Okay, your time starts now. Yeah, that's your time. You can start. This is your patient,
Yeah.
Anna.
Yeah. Hi, Anna. How are you doing today?
I'm good. It's just been a very emotional day.
Oh, I'm so sorry. I I know this is very overwhelming, and I wish we had like good news for you. So, you want some water?
Yes, please.
Yeah. Here's your water. And do you want anyone with you before we discuss what has happened further?
No, I'm good, thank you.
Yeah. So I hope you know what scan we have done, and I hope you know what we were trying to see.
Yeah.
Yeah.
I don't know. No, I'm here for my results.
Yeah. So how are you do? We will be discussing about that, but how are you doing?
I'm just I just don't know what's happening, and people saying a lot of words, it's just molar pregnancy and stuff, and I just don't know what it means. And then there's so
Um,
much information out there. And
yeah.
I've just lost my baby as well.
Uh, and I understand it's a very difficult situation for you, and I really hope the best for you. But we are here with you. Just I'm here with you. You need anything, like you want me to do anything for you, I'm here for that. So do you want anyone here with you to support you while we are having this discussion?
No, I'm good, thank you.
Okay. So I really wish we had better news to give to you today, but what the ultrasound shows is that yes, you have a molar pregnancy in simple words. That basically means it's a pregnancy, but how basically reproduction works, right? Like a sperm
Oh, I
fertilizes.
don't know how it works. No,
Yeah,
I'm not really
yeah.
familiar.
Yeah, don't worry. I'm going to like explain to you about it. So if you
Yeah,
see, this is the sperm, right?
yeah.
And this is the ovum.
Okay.
Okay. So sperm from your husband will come and fertilize the ovum. But the ovum also normally ovum has chromosomes in it, which means the genetic material.
Yeah,
Okay. But in your case, uh, the sperm fertilized the ovum, which had no genetic material.
yeah,
So, although you got pregnant because of the fertilization, it just means that there was no genetic material. In basic sense, there was no life in that. Okay.
okay. Yeah,
I know all these is very complicated to understand about it,
yeah,
but these are one of, the common things that can happen to anyone.
yeah,
Sometimes our ovums don't have the genetic material needed to form a complete baby.
yeah.
And unfortunately, in your case, the sperm has fertilized the empty egg. Okay.
Okay. Yeah,
So I'm sure you must be broken, shattered, but that's the news we have today. And it's okay. It's again not your fault at all. I'm sure you've done everything correct on your part. I'm sure you were trying to be a great mother, but these things are not in our hands sometimes. And it doesn't mean you won't be a mother again. You definitely, we can, plan for another pregnancy. We can have that chat another day when you're ready, when you're, when all this settles down.
yeah.
Okay. So what now the ultrasound is showing is the exact same thing. Like there is like, the features of a gestational trophoblastic disease. So now, with this, what we have to do further is we have to empty out your uterus. We have to remove the materials which have been, the remaining materials. Already, I think you've been discharging some, grape-like discharge must be coming out for you. So we'll have to empty that out. Okay, and we'll also do like so we'll have to in under anesthesia we'll put suction like we call it suction curettage. So we'll try to put an instrument and remove all the products of conception, and then we will have to send that tissue for a pathology. All
Okay.
right, because sometimes these can have the risk of turning into a cancer, something very nasty. So we have to make sure that we are safe. Okay. So, and then we will just continuously monitor your beta HCG also, because elevated beta HCG can lead to more nausea, vomiting, and it just leaves us with a suspicion of some other tissues maybe remaining there, producing this hormone.
Mm-hmm.
Okay, so we have to just make sure that no other remaining tissue is there, because it can complicate to conditions like choriocarcinoma or a gestation trophoblastic neoplasia. Those are
I
the
can have cancer. So I can have cancer from this?
not yet. I don't mean to scare you, but I'm just making you aware of some complications that can occur. And I just want to be on the safe side. That is why we're taking your tissue and we're going to sample it. So you don't
Okay.
have cancer right now, but I just want to make sure that you don't have it.
Okay.
Okay. And also, like, I know it must be a very hard time for you and your partner to take this. We can have some counseling sessions to help you with it.
Yeah.
You need any other support, you have any other questions.
So after this, and that's it. Like, I just have to go through the procedure and that's it.
Yeah, for now, that's it. And then we'll try to find out, like, what could cause this. Like, sometimes there can be a family history associated with it. Sometimes, as I said, there's no particular reason why this can happen. So we'll be continuously, like, maybe doing annual checkups for you, and whenever you're ready, whenever you feel like, I think I can have another baby, you can always come to us and we can plan out your next pregnancy with extra care.
Anything else I should know about?
That's it. Like, always look out if there is more bleeding.
That's it.
Yeah.
That's good.
Okay. I don't know. I forgot about
Yes, I figured that.
I forgot about the whole GTN.
Yeah. So tell me a bit more about that.
Yeah, like I just remember some empty ovum fertilization, like or partial ovum partial mole, full hybrid, all those terms. I forgot. It was my early MBBS days.
Yeah. Okay. Okay. So let's go back.
Yeah.
Okay. Tell me let's break it down a little, because here's a confirmed diagnosis of gestational trophoblastic disease.
Yeah.
Okay. So here in this case, what are the two types of? So what happened was your organization got thrown off because you started panicking. You stayed calm during the presentation of counseling, which is great, which is really good for you. But I can sense that you were thrown off because your format was off. So initially itself, you started saying, I wish we had some good news for you.
Because you were already crying, so I assumed that, okay, you knew it.
Yeah, I'm crying because I'm bleeding and I want this baby.
No, but I was like, does she know it? Because again, I read the question. Okay, she doesn't know it. Then again, that was the point where I was thrown off.
Cool. And I'm bleeding. So what's the rule that I tell you when you're bleeding and vomiting?
Hemodynamic stability.
Correct.
Yes.
Okay.
I thought she was already managed with all that. Okay.
You still need to check every time you come in.
Yeah.
Right? Anytime we walk into cubicle, whenever you assess a patient, the first thing you check is ads, because you can change it any time. Person can collapse at any time.
Yeah.
Right? Cool. And in her case, she can have remaining trophoblastic disease and can continue to bleed. Correct? And can go into DIC times. Does that make sense?
Yeah.
Cool. In terms of, okay, so going back. Now, is this a happy news, bad news, devastating news? What news is this?
Devastating only.
Cool. So what's the format?
Spikes.
Did you think of that in the 2 minutes outside?
Yes.
And then what happened?
You cried before I started my spikes. Usually the patients are happy before I start the spikes.
That's not true. I had my patients crying right before I started. I entered a room for patient crying. Okay, so you can't say, oh, you can't cry. I haven't started. Like, that's not a criteria. Okay. Like, wait till I open my mouth and then you can cry. No, that's not a criteria. Okay. So you need to. So I liked how you did the setting, which is good. I saw that. But then after setting, you lost it. Like, there was no perception, there was no knowledge, there was no, like, So take it
perception. I assessed, like, do you know why we're here? What are we doing? You were like,
No, that was after you said, I wish I had some good news.
Yeah, because you were crying.
Well, you made it worse by saying I don't have good news for you.
Yeah.
Okay. And what is the rule when you don't have good news? So always bad news followed by good news.
Good news.
Right?
Yeah.
And what is the good news? That you actually caught this. You can actually help her. You can actually treat it. You have actually people in this facility to help you, monitor her, and get you to the side where you can have a healthy child. Does this mean she can't have a healthy child?
She can.
She can. She absolutely can. So that's where that reassurance comes in. So you missed that. So that's why I kept crying. Does that make sense? I kept
Yeah.
crying because I didn't get that reassurance. So perception is very important. So hi, Anna. Now I see that you're upset and you asked me to hold all the right questions. You actually asked me if I wanted someone twice, right? And I see that you're upset. And the other thing you said was there's something else that you said.
I said it's
You
not
said
your
don't worry. I wish I
okay.
had myself like I would have thrown it at you. Like you can't tell me not to worry. I am bleeding. I've lost my
Yeah.
child. You can't say I can't worry,
Yeah.
right? It's a straight not okay. Okay, so setting. So you set the setting. So that was really good. You asked me, you comforted me, you were there for me. And then perception wise. So Anna, do you know what's happening with you at the moment? She's like, I have no idea. Like I said that. You actually asked me that. And I was like, I have no idea. People are throwing around words as molar pregnancy. And I was like, don't worry. I'm here I can explain all that for you. Would that be all right? Okay. Can I get you another tissue? You don't need to do tissue, water, partner all the time. You've done it once. You can just do tissue or water. Okay. And I wouldn't reinforce in the partner because then you're going to wait for a while for the partner. Okay. In case she says yes. So perception, then insight. Now, Anna, we have done the ultrasound. So next is insight. We've done the ultrasound. We have some findings. How detailed would you like to know about this? And what is your understanding of a molar pregnancy? She's like, I don't know anything about it. Okay, now this is where the crux of the counseling is. So you're going to be like, we've got your ultrasound result, and that has come back as there's an appearance called a snowstorm appearance. And as you may have noticed, when you are bleeding, there's like great plaque clusters that are coming through your provaginal area as you bleed. And this is known as part of a molar pregnancy. Okay, now I understand these are all big terms. I'm going to explain it, break it down to you. Is that okay? Okay, but before I move on, I want to say this is not your fault. Okay, women with gestational trophoblast with molar pregnancy can have healthy babies. That is something that you need to say in the beginning. It is not your fault. It has nothing to do with you, and you can have healthy babies.
Like in the future, right?
In the future. So you say people with
yeah,
in the future. Yeah. So you say people with people with molar pregnancies do have a higher tendency to have, you need to mention the risk as well because it comes in your management. That's why I was asking you, is there anything else I need to know? So people with molar pregnancy do tend to have a higher risk of having recurrent molar pregnancies and other complications, which I'll break it down. However, they do tend to have healthy babies with close monitoring and referring you to high-risk pregnancy clinic. Okay, are you with me so far? Okay, so like you said, so molar pregnancy is basically you have two forms of it. And actually, the two main forms. So one is called complete and one is called incomplete, right? Complete is the form that you have, which has come with like snowstorm appearance, where there's no fetal heart sounds that could be felt or seen. There are no fetal heart sounds that could be seen on the ultrasound, and also a fetal pole that's seen on the ultrasound, which is how a baby starts to form. So what it basically means that there's two ways that this can happen. One is where an egg, which is empty, is fertilized by a sperm, or you can have an egg that is fertilized by two sperms. Are you with me so far? So it can happen either ways. Okay. And the issue, the molar pregnancy is that it's a non-viable pregnancy. So you bleeding is actually a way of your body getting rid of a pregnancy that is not viable. Are you with me so far? Okay. Now, the complete molar pregnancy present like grape-like clusters and actually no fetal parts.
The incomplete can have fetal pods, and you can have, but they don't have a heart sound. This usually, it gets picked up at 10 to 12 weeks of gestation. Are you with me so far? Now, we take this condition very seriously, and you do have to be under observation, mainly because it does have a cancer risk. What is it called?
Choriocarcinoma.
Good, perfect.
And gestational trophoblastic incestual neoplasia, the GT.
GT.
Yeah.
So because of these risks, now, not everyone needs to have this cancer. We do keep you under close observation, and we need to do an investigation. Okay, so we're going to have a multidisciplinary team approach where you are going to be referred to an obstetrician. Your GP would be involved. And also, if you would like, we can also call for pastoral care. Okay, we can also have some social work if you need more support. Give a call to the social work if you need more support. And last but not least, your GP is going to be involved in your care. Okay, as you need serial bloods. Now, main thing about this condition, apart from those complications, you can have a higher risk of molar pregnancy. So if you are wanting to have a child, we'll have to have an early discussion with your GP and your obstetrician, and a referral to high-risk pregnancy clinic to plan your next pregnancy. Not right away. It is usually in a 6 months to a year's time of break. Does that make sense? Yeah? So what we're going to do is we're going to have you get some blood tests done. So which is your full bloods, a beta HCG. You've had an ultrasound already done. What are the tests that she need? She's bleeding, so you need full bloods and UECs and an LFT and a coag profile in terms of bleeding. In terms of molar pregnancy, she needs a beta HCG. What else does she need?
Blood group and antibodies.
Blood group across
And
match.
oh yeah, I forgot to tell about RH antibody. I was thinking.
So if she is, if you're RH negative, what do I need to do?
Anti-D.
I need to give you an anti-D, as we have to also think about your future pregnancies. Are you with me so far? Do you have any questions? No.
Do I need to know anything, doctor?
So we're going to go a bit more detailed. So after this is done, we're going to keep you under close supervision. So you jumped to treatment, then you came back to the blood test.
Yeah.
So we're going to do a bit more, blood tests. So once this is done, currently, because of your ongoing bleeding and your ongoing nausea, we do need to do a procedure called a suction evacuation. Okay, we need to basically, this is your uterus, and these are your molar pregnancy clusters. We're just going to have to dilate your uterus and then take out all the prior to conception out. Main reason, if we don't, you're going to continue bleeding and you're going to pose an increased risk for milk cancers. Are you with me so far? And there's no harm in saying cancers out loud because you want her to persuade her to get this done. Is that clear? Cool. Indirect persuasion, not direct persuasion. Okay, cool. So you're gonna refer off to the obstetrician for this you need to get admitted now. You need to, if you're in an EGP setting, please send her to ED because she's bleeding. She's not going to go direct admission. Okay, since she's in she's already in a hospital, we're going to get you to see by the home team. We're going to refer you to my senior right away, and we're going to get you consented for the procedure. Is there anyone else? If you want, I can call your partner in for you during this process. And we can get you consented and get you to the theater as soon as possible, as we want to stop your bleeding. And if your hemoglobin's very low, I'm going to also give you some blood. Is that clear? Okay. Main thing I want to do is, in the meantime, I also have to keep monitoring your blood pressure. What is it called? The complication of gestational trophoblastic disease? It can cause preeclampsia.
Oh, okay.
Okay, so please do let me know if you have any severe headache, epigastric pain, and you're having any visual disturbances, and we have to keep an eye on your blood pressure. Are you with me so far? Cool. Once this is done, what happens is we are going to send the sample off and we're going to have a look at the sample and rule out any sort of cancers. We're also going to keep a serial monitoring of your beta HCG until it comes back to normal. So the beta HCG, we keep an eye on it. We do serial beta HCGs and it can be done through your GP. We see with the ideally, your beta HCG should be starting to go down. If it's starting to plateau or it starts to go up, we get worried. Okay, so I draw this graph right away. So if it's going down, it's all well and good. We keep assessing you till it gets back to 0. So if you're having a complete molar pregnancy, it becomes 6 monthly. If you're having incomplete, then it becomes a bit more frequent. Okay, once it's to 0. But if it's plateaued, then we need to do another ultrasound and we need to see why it's plateaued. And if it's going up, then you're going to get an urgent referral. Are you with me so far?
Why does beta HCG keep increasing?
Choriocarcinoma.
Okay.
It's a tumor marker. Is that clear? And then if it's going up, we'll have to do further investigations with some imaging, which is CT. Are you with me so far? Any questions? Now, again, I'd like to reassure you, once this is all done, you'll have a brief period of like giving your body some rest for 6 months after your beta HCG is normalized. And then we can plan your pregnancy with having a meeting with the GP, doing your antenatal screens, and having and referring to high-risk pregnancy clinic, and keep an eye on the next pregnancy to have a normal pregnancy. Are you with me? So we just have to keep an eye out for you, okay? And the reason we don't bang on right away have another pregnancy because you increase the chance for another molar pregnancy. Does that make sense? So that's 1 year break is very important because her beta HCG normalizes actually takes about 6 months, and then she needs a period of 6 months without actually getting pregnant. Is that clear?
So do we have to tell them about contraception as well for these 6 months?
Absolutely. So the main reason I'm telling you is that I would advise you to use barrier contraceptives such as COCPs and try to avoid any estrogen pills for the time being while your beta HCG is coming to normalize.
Yeah.
Yeah, absolutely. You have to talk about contraception. That is
So immediately, if she has a baby, there are high chances. So that's why 1 year of break.
Okay. And if you do fall pregnant, please come back to the GP right away so we can have a close eye on you.
Yeah.
Okay. That's it. In this case, it's already an urgency because she's bleeding and she's having a molar pregnancy, and she said you don't have to give any more reading materials or I mean, you're going to give reading material, but there's no other further referrals. You're going to take her to theater right now, and you are going to give her, you're going to consent her, give her some red flags for preeclampsia, and that's about it. Does that make sense?
Yeah.
Yes.
Any questions regarding this case? Everyone's clear on this case. And there's a small note of people who are in my course, you guys have access to Google Drive that has breakdown of trophoblastic disease, ectopic disease, and the other document. I'm just trying to see what it says. And this is a very common case. It used to be much more common and it's come back again. Okay. Any questions?
KP, how we will start like the hemodynamic stability, we'll ask to the examiner only, as soon as we enter, like if
Yeah, so
bleeding.
I like to ask it in 2 ways. So I like to approach the patient first. So I like to go to the patient and say, "Hi, my name is Priya. I'm one of the doctors I'll be looking after you, Anna. And now before we start, can I ask you, are you having any dizziness or palpitations, and are you feeling unwell, and are you having nausea, vomiting?"
Mm-hmm.
Yeah, I like to ask this
Okay.
4 questions, 2 by 2, and then just excuse me for a second. I'm just gonna have a chat with the examiner real quick, and I'll be back with you. Is that okay? Good. Go back to the examiner. Yeah,
Okay.
examiner.
Okay.
What are you gonna do? You're gonna put IV line. You're gonna put an IV line. You're gonna move her to the resus room or treatment room, and you're gonna give her take bloods, and you're gonna give antiemetic and painkiller. Right?
Yep.
Cool. So
Okay.
just don't forget those. Okay.
Okay, that we need to tell to the examiner, like I want to move to the resuscitation room, IV cannula and whatever that we have to tell to the examiner, right?
Okay.
And if the bleeding is there and in the stem vitals are stable, like mentioned, do we need to again ask to the, because I had an experience, they are asked like stick to this task, like because bleeding is there in the stem and even vitals are stable, BP vitals are there, then do we need to ask again?
I would just say I would like her to move her to the resusc room and I'd like to check the vitals again, please. Or may I know if the vitals are still stable? I ask one statement. I don't ask blood pressure, heart rate again. I just ask, are the vitals still stable? Because it's a subjective exam and each examiner can be different. So for me, I do check if the vitals are still stable. Does that make sense?
Sure.
Cool.
Yeah, thank you.
And guys, another thing, in the beta HCG, there should be 3 serial beta HCGs normalized before she can conceive.
How many months apart?
They usually a couple of weeks apart. They're done a couple of weeks apart. It depends if you're more complete or incomplete molar pregnancy. And then the other thing to kind of consider, I think that's about it. I think that's all you need to know. You won't have time for anything
I
else.
think every month they're removing something from the gynae. They're adding. Last time it was endometrial hyperplasia. This time it is GTN. They're trying to increase the portion.
Yeah, because you'll have an average of like 2 to 3 PV bleeds
Yeah.
a week. It's that common. So just be careful. Like we are also, like I had a lady that we had to transfer for ECMO because she bled so much from her pelvis. They transfused about 6 liters of blood.
So we have to read about each differential of the bleeding period.
Does that make sense, guys? Okay.
Yep.
Cool. All right. Next, who's next? Does everyone understand trophoblastic disease really well? Was that helpful? Did
Is there
everyone
any
find that helpful?
guideline that you attached?
Yes, I posted on the group.
Yes, I can see it.
Yeah.
Sorry, what group did you post?
No,
Not the group. It's in the
Chat
it's in the
box?
comment section.
Yeah.
It's in the comment section.
Mm.
All of the guidelines we've been posting in the comment section. I'm just trying to see if there's one more guideline that I like you to follow. I put the Ranscog one because there's a nice, beautiful chart in there. This is the one that SA Health doesn't really have a good. I'm not too impressed with their molar pregnancy guideline. They have ectopic really well done, but they don't have molar pregnancy well done. So I would say this one, do the Ranscog, because they have done it really, really well. Yeah. In terms of, I'm just trying to see if there's another guideline that's really well done. No. So that is ectopic. Isn't it the trick set deal? All right, cool. Station 4. Who's 4?
Me.
Let's do it. Ritika, you got this. Swarna, does that kind of give you an idea of what you need to work on? So even if you're panicking, I know you're panicking, but then did you write spike in your form, in your paper?
Yeah.
Good. So restructure it. Go back.
Yeah.
Okay.
So I always get stuck near the I. I is the info, right? Like how much info do you need? Do you want me to go in detail?
They always say detail. They always say I want
Always
detail.
forget that. Yeah.
They always say detail, so go in detail. Just prepare yourself to go in detail.
Yeah.
Okay. It's an exam, so they're going to say detail all the time. But it's just courtesy question. Okay. Cool. All right. Liz, you're up. I'm going to start. Ready? Set.
The next case because next one is fun. So.
Oh, okay. All right. Cool.
Yeah.
I'll do the case. Okay.
Yeah. Sure. I'll start the timer and you're ready, right? Who was it?
Yeah.
Rutik. Your time starts now, and this is the case. Where is it? Where is it? 1 second. Ah, there you go.
You guys finding this useful in the participants? Any questions? I know it's kind of a lot of talking. If you guys are finding it useful, can you guys put it in the comment section? We'd love to know if it's helpful. If it's not, then we don't want to.
No, it is useful, absolutely useful.
Good, thanks, Ritika. Ben's giving me a thumbs up. Yay. Rupa, Sai, Susan.
Oh, this is station 5.
Yep, you can start. So this is your X-ray that you wanna explain to the mother.
Oh my God.
That's the first response. Yeah, carry on.
Can you please go back to the previous slide?
Okay.
Hi, Lisa. I'm Dr. Rutika, one of the doctors working in ED. I can see that Jack has swallowed some foreign body, and we have done the X-ray as well, which I have the findings for you. I know that you would be worried about that because he has swallowed the uh, battery from remote control. So from the X-ray, we can see that. So if you can see this is the X-ray, what we have taken in the emergency department. Uh, can you please go to the X-ray now? So yeah, I
Isn't
can't.
it the X-ray? Isn't it the X-ray that you're seeing now?
Now I can see the X-ray. Yeah.
Oh, okay, sure.
So this is the X-ray, and if you can see the round thing which is lying near the stomach, so the black shadow which is just right to the white shadow, that is the stomach shadow, and the white thing which he has swallowed, that's at the entry of the stomach, the esophagus and the stomach. So the background you can see is all those this that is the spine, and the whatever the battery he has swallowed is lying in his stomach. To be honest, I don't know how to explain the X-ray. Sorry.
Just try your best, doctor. You can do it.
Yeah, you can try
Yeah, just
whichever.
try your best and then you move. It's an exam, right? So what do? So now you see that it's there, so you can see that, right? That's the main thing.
Yeah, so luckily, what I would like to say that luckily it is in the stomach and not gone into the lungs, because if it would have been in his lungs, then that is something emergency which we need to take it out by doing the procedure by the specialist. But because now it's in stomach, likely it can go into the intestine and it can come out from his stools. So if you can give him some more fluid, some high fibers in the diet, and then it might come out of his stools, which we need to monitor, or which we need to find out every day whenever he will pass stools. Just we need to observe if it has come out or not, because it is from the stomach, it can go into the intestine, and then with the peristaltic movements, it can be thrown out of the body.
Okay. All right. Anything else I should know about?
Yeah, so I would like to suggest you to give him lots of water to drink, lots of fiber, and then it will come out.
So right now, I'm just sitting and watching him.
Yeah, doctor, I want you to focus on the tasks too. Yeah, you can move on to the next task.
Yeah, so
So
that would be
so I just have a question. So does it is but I heard so I Googled it and I noticed that the button battery can actually like it can actually cause the tummy to burst and like it actually can erode. So I'm a bit worried. Does he not need to be taken to the theater?
because if it was in the lungs, then definitely we would need to take it out. But because it's in the stomach, there is a possibility that it will come out on its own. But we can observe the signs of lead, like if it's made up of lead, then we can just observe the signs of some red flags, like if he is having some maybe vomiting, some blood in the stools, any pain in the tummy, then it might be eroding the gastric mucosa, like the lining of the stomach or the intestine. But if he's playing well, no signs of any infection like fever or anything, then it will come out on its own.
Okay. Anything else I should know about?
Mm, do you have any other concerns?
I'm just worried that he's yeah, that he's, he swallowed it and about 3 hours ago, and I'm just like really, really worried. Like if he could like burst his gut and like, rode away. And how do I know that it's gonna come out? Because he poops on his own, like, he does so like we don't, it's hard to check the poop.
So better would be if is he toilet trained or if he still wears a nappy.
He wears a nappy.
So better would be whenever he will poop in the nappy, it's better to always check whether it has come out or not. Because high chances are it's lying at in the like it's at the entry of the stomach and the intestine, so it will come out through his potty. So every day when he will pass stools, it's better to check his stools to see if it has come out or not.
Okay. Anything else I should know about?
Yeah, and if there is any blood in stool, if there is any pain in the tummy, or if he's vomiting or feeling drowsy or fever, then bring him back immediately to the emergency department.
Okay. Okay. So I can go home now?
Yes, you can go home now.
All right. Anything else I should know about?
I don't know. I think I know I have messed up everything, but
You can't say that. You're so role play. Anyone else want to add on? Foreign body ingestion is a very important
We
case.
have 30 seconds remaining, so you're not using the 30 seconds, right? We are
No,
stopping it.
she's done.
Okay.
She's done.
Yeah. Okay.
All right. Anyone else who wants to jump in real quick? Apurva, you were saying something. Swarna?
Yeah, that's it. So button battery is like an emergency condition. So first make sure like explore the incident properly, who was taken, like who witnessed the incident, when did the incident happen, what were you doing when he swallowed. Those questions are important, like ruling out
but
NAI.
history is not asked. There is no
Oh,
history
there's no
task.
history. Sorry, I was.
So what do we do? So like you said, bottom battery is a concern, right?
Yeah.
So bottom battery is a concern, and how do you, without taking history, make sure that he's okay?
Sorry?
The
Later,
task
let's
doesn't
say.
have hemodynamic the task does not have any history, right?
Yeah.
Yeah.
So like you without asking the history, maybe like you
How
have
do you check? Yeah, so how do you check that the kid
Vitals,
correct? And what is
right.
that? So how do you do that?
Especially
SpO2.
No, how is it SpO2? Think about it
uh,
properly.
the choking, the coughing, drooling, and if any abdominal pain is there, if
Okay, so
there's any
but
GI
you've already
bleed.
seen the X-ray, and
And
Yeah.
it's
then,
go back to the X-ray. Okay, so let's talk about X-ray findings. Let's talk about that first. Okay, and then we'll.
mm,
All right, where is it on the X-ray? Do you see a foreign body in the X-ray?
yeah.
Yep. Yep.
Yeah. Okay, and we know so it's confirmed to be a bottom battery, right? Like, because it's not unwitnessed
Double
form.
halo sign. Yeah.
Perfect. Okay. Where do you reckon it is? So you explained it really well. So first of all, whenever you're explaining an ECG or an X-ray, see what it is. So this is an X-ray of your son's abdomen and pelvis. So it's your stomach and pelvis. It goes from just below the chest all the way to the pelvic region, so we can see all the intestines. Okay. So the main thing is that what you're seeing here is on the little haze on your left-hand side is the liver, and all these little bubbles you see are all your intestines, and that white, really highly dense white opaque object you see is the battery that we see. Okay, and as you can see that before you see that it's quite like a big bubble before the battery, that is your stomach, and as it goes, it's going into the first part of the small intestine. Are you with me, Soa? It's going into the gut. So that is one of the junctions where the battery travels through. Are you with me so far? But apart from that, I don't see any air under the diaphragm, which is that just above those ribs. You can actually point it out, so it's actually fine. And that's something that we worry about as a complication if it's going
Perforation.
through the stomach and actually complicated where the gut has burst because of the battery eroding. Does that make sense? Because that's my question, right? That's my concern that I had for you, right? So it's reassuring that the bottom battery is actually past the esophagus, which is your food pipe. It's past that, gone into your stomach, and actually gone past the stomach. It's at the It's at the junction of the stomach, entering your gut. Yeah. So we're gonna go back and so what happens? So and apart from that, I don't see any other anomalies. So take a minute. I don't see any other abnormalities in this X-ray. The pelvis and the gut all looks good. There's no signs of obstruction either. Does that make sense?
Yeah.
Okay, that's it. It's a good exposure. It's a PA view of the X-ray. It is of your abdomen, pelvis, and I could see, and then you explain the gut and all those parts. Work your way from outside to inside. Does that make sense? And stay organized. Okay. Once that's done, I'm going to discuss management. So when I say discuss management, don't just straight go to what he has. Go back a little bit. Okay. So as you have all the right to be worried, the bottom batteries are concerned, as they can erode and they can cause complications. However, your son Jack through the X-ray we can confirm that he's only taken one button battery. Remember, more than one is a bit of is a risk factor and needs to go for endoscopy. Okay, and also through our X-ray findings. Sorry. Through X-ray findings, we also found out that it's also past the food pipe, which is where we would be concerned about. Okay, since he's taken it he took it about 3 hours ago, and it's past the 1 to 2 hour mark, we tend to not give anything. So if it's within the 2 hour mark, we sometimes can give him honey, which helps coat the battery and kind of pass through. Are you with me so far? Okay. Now prior to doing all this, I've done before the X-ray findings itself, I would have asked about the hemodynamic stability of the child. Is my child alert? Is my child actively vomiting because dry retching and trying to bring it up? And is my child having any tachypnea,
breathing difficulties because of the perforations and a foreign body, drooling. So main thing is I would ask about, don't jump into oxygen saturation right away because it's a peripheral line, right? Have you seen kids getting very irritated? You can't get a good SATS reading. So you can't actually rely on that. Your main hints would be, is a child irritable or calm and comfortable? Is a child actively vomiting? And is my child, what's the respirate of my child? What's the blood pressure of my child? What's the heart rate of my child? And then SpO2 and temp. Okay? You're welcome, Sorna. So does that make sense? Okay. So main thing is you need to know that. And then once that is done, you've seen the foreign body, you've done the x-ray, you've gone to talk about the actual management. So one of the main things that he has swallowed, some of the risk factors that we look for is that, is he vomiting? Is he having tummy pain? Is he having breathing difficulty? And if he's having drooling. As your son's not having any of that, he's actually quite stable, and he swallowed this 3 hours ago. If it was within the 2 hours, we'd sometimes give him honey to coat the battery. And the other risk factor that we worry about, if it's stuck at the food pipe. If it's at the food pipe, we would immediately tell him to be taken for an endoscopy. An endoscopy is where we put a camera down and we see if we can take out the foreign body. Are you with me so far? Okay, so it's really reassuring that it's past the food pipe. So what we wait for is that however, even if it's past the food pipe and it's in your stomach and at the junction of the intestine, if he's having severe tummy pain, nausea, vomiting, and he's having breathing difficulties, then we would have to take him for the scope as well to look down and get the battery out. Are you with me so far? Do you have any questions? No. Okay, good. So main thing is that if he's asymptomatic and if it's crossed the 4-hour mark, okay, once it's crossed the 4-hour marks, and if he's completely fine, he's very calm and alert, and he's not having any difficulties, what I'm going to do is I'm going to actually have a chat with the ENT doctors and the gastro doctors and get back to you if that's okay. Because it's still a button battery. I cannot discharge you without that.
Okay. Yeah.
Does that make sense? So we'll have a
Yeah.
multidisciplinary team approach. We'll have a chat with the ENT. We'll have a chat with the gastro team. And well, in this case, it would be the gastro, not ENT. Sorry, apologies for the mistake. So he would go straight for gastro because it's past his esophagus. If it was above, I would go with ENT. Okay. And we'll also have a chat with your GP as well to keep an eye on your child as well if he's aspirated, and to start some antibiotics if he spikes the fever. And in the meantime, just keep an eye on him for a little longer in the department just to make sure that he's not having any complications while I do this chat. Are you with me so far?
Yeah.
Good. Perfect. And in the meantime, what we need to consider is I'll give you some red flags, which are the flags to monitor, which is you need to make sure he's not vomiting, not having breathing difficulties, all the ones that we talked about earlier. Okay? And
Yeah.
fever and melena as well, please. Sorry, I forgot to mention that. And go along your well baby questions. Do you have any questions for me? No. Do you live close by? Why is that?
So if something happens, can come back directly to the
Right
emergency.
away. Because if they live far away, say this happened at 10 o'clock at night and they live in a rural country, say 2 hours from here, are you going to discharge them?
No.
No.
It's an overnight admission. Does that make sense?
Yeah.
Yeah.
That's the only reason. So remember I asked you, can I leave? So that's the main reason for that question. Make sense?
Yeah.
Yeah.
Cool. So main thing and because it complicates the situation with RFDS and all that, and a child won't survive. Does that make sense? All right. Any questions, queries? Everyone understands foreign body, guys. It's very common. It's been coming so often. And kids swallow every single thing. The number of things that pulled out of all the orifices, it's intense. Okay, so please, they eat a lot of things. And the other thing is also to make sure that this is not happening quite often, like that the child actually has someone to review and keep an eye on. Okay, like I always tell this to everyone. Just a month and a half, 2 months ago, I had a child that was high on methamphetamines. Okay, accidental ingestion. Child was intubated and taken, and the child's brain was being fried because she started spiking at 10 per 40 and tachycardic at 200. Blood pressure also spiking, going into hypertensive crisis. Okay, it's a serious, and kids have something called one pill kill. One thing, one pill, or one of that is enough to kill them, which is like propranolol, your gliclazide, all of them, which is just one pill kill, which are common drugs in your elderly, and like rat poison, toxins, lead, lithium. It can be picked up on X-ray, but it's very toxic for kids. Does that make sense?
Yeah.
Yes.
I
So
know.
then do we have to admit them for overnight
So
stay, or only if it's rural, then only we have to admit them?
only if it's rural and after advice. After I'll check with the specialist and I'll get back to you is your
Yeah.
advice.
Yeah.
Okay. In terms of, so it doesn't really necessarily need to be in the lungs for it to be like a issue. Does that make sense?
Yeah.
Yeah. Okay. The other one that becoming more and more, I don't know if you guys will get it in the exam, but if you do as a pilot station or even as a station, peanut aspiration is one of the ones that is coming up a little bit more in foreign bodies. I don't think you guys have gotten it just yet. If you are, I think it's most likely going to be a pilot station. So peanuts are your what do you call? They give an enzyme that actually causes your airway to actually, it actually goes into airway when they aspirate, and it actually causes fibrosis within the airways within 48 hours. Okay, because of the
What's
oil,
that?
peanuts, because the peanut oil is highly reactive and can cause that. So any child that's a peanut aspiration, don't discharge them. Definitely don't discharge them. They will need probably a bronch. That'll be an ENT surgeon. Is that clear, guys?
Yeah.
Okay. Any questions, queries? Yeah. Thank you for all joining today. I hope the session was helpful. And we're going to be trying to do more sessions like this. And you can opt in just to come for recall classes. We'll be advertising it. I'll be putting it up in my website, or you can just reach out to me directly and I can give you the details. Basically, we'll be doing recall sessions monthly. We're going to be deciding the next date. We are tentatively for August 14th, but we're going to be pushing that to somewhere in the week after in August. And we'll be having, and in the meantime, we have Dr. Taneya's class for obstetrics that'll be coming, and it'll be only obstetric cases. So it'll be broken down to first trimester, second trimester, and third trimester, and then postpartum cases. So please, if you're keen, to let us know and come down, okay? Thank you. Thank you. Sorry if I pronounced it, Toan, for coming and joining us today. Any questions from today's cases? Can you make a group? What kind of group, sweetheart?
Like any Telegram or WhatsApp group.
Sure, we can. And what would you like to? So we were
Thinking.
thinking, yeah,
Yeah.
we were thinking about it. What would you like us to? Because there's so many groups, right? There's so many groups. So we're a bit reluctant to start a group just because there's so many groups and we don't want to confuse you guys. But if we were to start a group, what would you like to know from us? And what would you like us to post on the group?
A more monitored practice.
Like more monitored. So that's what we are actually announcing. So we have, do you have the dates, Liz? Do you want to post it on the group? So we have more monitored practice. So what we have is this month is obstetrics, next month is medicine, the month after that is psychiatry with Dr. Shruti, and we have Dr. Arth teaching medicine as well the month after that. So sorry, not medicine. Dr. Arth will be teaching
Medicine.
Medicine, sorry, yeah. Sorry, Arth is teaching medicine, and we have Dr. Sonal. So all of my doctors are working in Australia, and they are registrars and RMOs, and actually trainees. Like Dr. Virpal is pediatrics, and she's an ED trainee.
Dr. Sonal is a BPT physician. She's actually a consultant from AIMS University in India. Then we have who else? Madiha, who's a GP trainee that's done surgical and medical, who'll be taking your gynae classes, and she's doing gynae rotation at the moment. I am ED and ICU. So I'll be doing your emergencies and ECGs and BPGs and your recall classes. And who else? Dr. Liz helps me with the counseling and arranging your classes. So you can also reach out to Dr. Liz, who will be also helping you manage all of this. Apurva, if you can actually structure what you would like, I'm more than happy to do something and create something.
Can I get your phone numbers, like, if that's okay? Because in the form, we did ask for email and phone number, but none of you guys actually gave the phone number. You only did the email. So it was really hard for me to, send out the links. I don't know if people have checked the emails. So can you
I
text?
have your number. I will text you.
Yeah.
Yeah, this
Text
is mine.
your
I
number.
messaged.
That's good. Okay.
Hey,
Yeah. Sure.
Dr. Priya, I have a question. Hey, can you hear me?
I can hear you.
Just about the groups, because some of us, literally, some of us who are doing exams in October, we barely have like 2 months. So it will be good to really attend the courses. But then you see, you're doing an obs kind case next month, and then the other month you're doing medicine. The other month, I mean, it will be time for exams. So what about if you have like a structured recall session like this, like just for recalls, recalls and
Just
revision?
recalls?
Just
Okay.
recalls and revisions. I mean, I'm happy to pay just as long as I can be able to speak out and someone can correct me so I can polish. Because you see,
I want you
even
guys to role play. Yeah, absolutely.
even joining your unlimited session, like barely we have like 2 months. So basically that becomes a bit tricky. Are you able to consider something like that just for rapid recall session, rapid revision, especially for guys who have exams coming, like maybe September, October guys?
Okay, yeah, that's absolutely a fair question. Can I ask you guys, if I was to do that, how many classes a week can you guys actually attend? And so question would be, how many classes a week can you attend? And how many classes a week would you want?
As much as possible. For me, as much as possible. Just the timing. I mean, I find three, because I also work just like 3 o'clock, like that's you're basically working. So maybe something from like 5, 6 thereabout. I'm happy to attend all the classes and pay for them because.
And are you okay? So there's two options you can do. So either we could do a group and you can do one-on-one. So if you want one-on-one, which is like just dedicated to you, so just have a think about what structure you would like, one-on-one, or would you like a group? And in terms of so as much as possible, that might be a little hard because I'm in ICU 20. I've just come off my nights this
Okay,
morning.
twice a week, thrice a week. It
Yeah.
doesn't have to be every day. So it just depends. But maybe a group can work. If there's no group, I mean, we can discuss one-on-one. If there's no group, that is actually like.
I can join her because even I have exam in October, so I can join Susan.
Yeah, I think twice a week for 2 hours each session in a group would be the best, I think.
Okay.
I am happy for 3 days as well.
Can I then ask
Yeah.
a favor from whoever is interested? I will put you guys have my Instagram and Liz's Instagram or my email? Actually, more than email. That's where to track you guys.
Can I get their numbers too? Like, Susan, can I get your number too, if that's okay?
I'm just posting it over here.
Yeah, WhatsApp number.
You guys can give Dr. Liz your numbers, whoever is interested, because we only want to do serious candidates. So whoever is interested, give your numbers to Dr. Liz, and me and Liz will have a chat tomorrow and kind of structure something up for you guys. Is that okay?
Yes, we'll really appreciate.
Okay.
Yeah.
And are you guys happy with us? Okay, so the second question I want to ask was, do you guys want that subject-wise, or do you just happy for me to pick any questions and just rapid fire?
Subject-wise.
Yeah.
Subject-wise.
So if it can be subject-wise, until we're able, like for the 2 months, so that by the time we're going for the exams, we've covered everything, that would be really helpful for us. Because you see, you only know what you don't know. Because, I might think I'm really good at this, but only if I role play, I'm like, oh, I really don't know much. So only if we can practice subject-wise and just revise what we know.
and like high
Yeah,
thing. So maybe psychiatry is definitely we are going to have cases on psychiatry, obs gynae, peds, and physical examination. So even if we are perfect in these four subjects, then there is a high chance that we might pass the exam.
If any
yeah.
of you live in Perth, we have a face-to-face physical exam 5-day course coming up, 8 hours a day. It's an 8-hour course where Dr. Manas and I take in September from 7th to 11th of September. And we'll be, if you're in Perth, we'll be doing that. It's a face-to-face course and lunch and everything is provided for you guys. So hit me up if you guys, if you're in Perth and you want to join us for that. The other one and the other subject was, are you guys happy with a combination of me and Dr. Tanaya and like Dr. Liz like a combination for us to work and
Yeah, yeah.
Yes, yes,
Right.
yes. And even online physical examination, I'm also happy to pay for that, if it's available.
it is we're happy to make it hybrid if you're happy to sit 8 hours.
Yep.
Okay. It's a long hour. Yeah, and we do have speakers also coming at that time. We have who's coming? We have some speakers to come and help you with IMG workforce as well, like to help you guys get into the workforce. We're just hashing out the details on Monday, like for your CVs and stuff. We have someone from AMA coming and helping you guys. Okay, cool. Whoever is interested and whoever is happy to move forward, can you guys all shoot Liz an email or Liz a text so we have the number so we can create the group and we can then kind of have discussions on the group and create that. Is that okay?
Okay, so we can separately text what we actually want, right? Not the whole
Yeah,
session, only okay.
yeah,
Accordingly,
yeah,
we can plan.
yeah. Like there's no locked in contract.
Because actually, like I say, second time we have some materials. Only we need the practice with a professional because we have
Yeah.
few study partners, but we just role play. We know their what we are just expecting their answer. Especially in psychiatry, like the way you act, nobody can. So when we practice among us, it's not helping actually. So and you
Yeah.
are giving the feedback. Actually, when you act, I was like, okay, I was remaining some I mean, the role players in the examination station. Like I got stuck somewhere. So the same scenario we can practice actually. So that will be helpful, I think.
That's fair. Yeah, I know I've been told I have a great acting skills. Especially for psychotic patients. I feel like I think I've
No,
seen too many
actually, I
psychotic
really had a
patients.
burn case. Actually, I was prepared for that, but when I saw the role player, I got panic. He was so restless, and I got panic, and I missed everything. So
Yeah,
even I forgot the hemodynamic, as you told, the resuscitation, and it was like more than 10% burn case as well. So we need to practice that.
yeah, and that's the main thing. Like you actually being immunized to actually what the patient will present, especially psychiatry cases. Like Dr. Shruti is absolutely amazing with her psychiatry. I'm sure some of you guys come into our previous classes and done mocks with her have seen how crazy she can go with psychiatry. That's why she's chosen psychiatry
Yeah.
as well. So, and she works in ED and she wants to go to ED. So she will also be a great one that I would suggest you to attend. All right, good, cool. Just what I would say, yes, absolutely. Shoot, Liz, are you happy to take that? Would that be okay?
Yeah.
Cool. Just if you guys can shoot Liz an email and then kind of like we'll make a group and then we'll have actually a formal chat on the group and
Yeah.
like see what you guys want and kind of get this going because you guys have exams too soon, like really
Yeah.
soon to get
Yeah.
this.
And also, if you can be able to just organize for us like a mock, just to see where we are, probably sometime before the exams so that you can have time to go and read again. And then that
Absolutely.
would be
I
awesome.
personally don't do mocks. I'll be very
Yeah.
honest, just because my time schedule. I'm working 13-hour shifts 4 days a week. So I personally don't do mocks, but Susan, I do have Dr. Shruti, Dr. Arnav, and Dr. Ahmed that do mocks.
Yeah, just as you said, because you see, I'm practicing with my partners, my friends, so they only know as much as I know. So
Okay.
basically,
Yeah.
getting this professional feedback becomes, so we don't mind whoever, as long as you can help us organize, that will really be helpful.
Yeah, and Dr. Shruti and Dr. Arnav are like usually quite booked up. So can you give me your dates ahead of like as soon as the session's over, because I'll have to look at the calendar because they are quite booked, usually booked up.
We want to do it as a group. Mine is 15th of October.
Okay.
15th of
Just
October.
send me a dates when you can actually do the exam, like what date, what week you're looking for the exam.
Or rather, okay, that's okay.
Like, so all, what you do is basically how it works is you go back to calendar saying, hey, Dr. Balan, I would like a mock exam on this week of this month. Are you able to arrange one? So then I basically take your information. I check which which mock examiner is available, and then I arrange a time and a date with them, and then I send that to you. You confirm. I send you. You make the payment. You get the Zoom link, and the session starts. And you'll get a written feedback in 3 to 5 business days. You'll get a verbal feedback at the end of the session.
Okay, that's okay.
Yeah.
Yep.
Is that what you're looking for?
Yeah, but first of all, just if you can just help us form a group first, and then probably we can discuss from the group on what what you can do from there. We will really, really appreciate. It's been a very, very helpful session. Yeah.
Good. Absolutely. That's absolutely fine. Yes, Apurva. No, you're not. I think it's your headphones. Can you hear me? Should see my psychiatry actions in person. I think Dr. Vibha was scared, right? After my one-to-one session. Yeah. I think she still has PTSD from it. I think I was a schizophrenic person.
I experienced once in Bangalore.
Oh yeah, that's true. I think everyone got scared after that session. I remember that.
That cockroach lady you were.
Oh yes, the cockroach case. Everyone got scared after that class. Everyone became quiet after that class.
They do that. They usually act, they are like that, Dr. Apurva.
Yeah,
The subject like that in actual exam. Yeah.
Yeah. The granny's absolutely sweet, but she's all the candidates in the exam, they're exactly how I acted it out. And that is the reason I kind of am changing the structure of the exam, because you guys can all read your notes. There are hundreds of notes outside. There's hundreds of theory material, but to pass the exam and to get into the workforce. And there is a positive note that they're changing the workforce into those candidates who have passed their clinical exam and trying to recruit more. So that is happening. So I would say pass your exams. Okay. Does that make sense? Yeah. Yeah. If everyone just who's interested, shoot your messages to Liz and we'll take it from there. Okay?
Yes.
Yeah, sure.
Thank you.
Hit me out.
Bye.
All right, guys.
Thank
It was
you.
really lovely to meet you, and everyone who participated today. I really appreciate you guys participated. Sorry, Neerja, we couldn't get to case number 5. Do have to pick up my daughter now, otherwise I'm gonna get yelled at. And I will see you guys next time. Bye.
Thank you. Thank you so much.
Bye.